So students, let's discuss some of the important points that are likely to come in the INI-CET paper. Capgras syndrome, Frigoli syndrome is always a favorite of INI-CET examiners. We have to remember that when the question says that a close person got replaced by a stranger, it is Capgras syndrome. Close person got replaced by a stranger. And when we say that close person is disguising as a stranger, this is Frigoli syndrome. Close person is disguising as a stranger or multiple strangers, that is Frigoli syndrome. Antipsychotics with minimal weight gain, important point for your INI-CET exam. We have to remember 3 A's: aripiprazole, acinapine, and amisulpride. We have cariprazine, we have ziprasidone, and we have haloperidol, likely to be asked in the exams. Okay? TCA toxicity, they will present you a case, they will give you a case which will have anticholinergic symptoms like dry mouth and increased temperature, not sweating, right? They will also add some CVS and CNS symptoms, that chest pain is there is decreased respiratory rate, there may be convulsions, and they will probably throw the ECG findings. We know that prolonged QRS interval is the most important ECG finding. If the QRS interval is more than 100 millisecond, we have to initiate the treatment in the form of sodium bicarbonate. One of the favorite questions likely to be asked in the exams. Antidepressant with minimal sexual side effect, another important question. Bupropion is one, miltazapine is another, and agomelatine is the third one. Remember, likely to be asked in the exam. In the OCD treatment, remember that the first line treatment would be your medical treatment would be your SSRIs or clomipramine. If you have to pick one, you will pick SSRIs. Often the patient do not respond completely to SSRIs or clomipramine, then you have to augment. And for augmentation, one of the best drugs is a antipsychotic, one of the antipsychotics. We use risperidone and aripiprazole more. One of the drugs, newer drugs, which is being increasingly used, might be asked for OCD, not a first line, third line maybe, is memantine, NMDA receptor antagonist, memantine. If they talk about the therapy, then it is the best therapy is, or the therapy of choice is, exposure and response prevention. For postpartum depression, 2 drugs have been approved. One is zuranolone, the other is brexanolone. Both of them are allosteric modulator of GABA A receptors. This can be asked in the exams.
Everyone has a plan, but they change after the first punch on the mouth. Hello dear friends, myself Dr. Shrikant Verma, international educator and author, faculty of anatomy at Cerebellum Academy. So dear friends, remember, till the last day, till the last moment, we have not to change our game plan. We studied in a very nice way. So whatever we studied, we revised also, we given the test, we prepared very well. 80 to 90% topics they are going to ask from the same topics, either directly or indirectly or integrated to the other questions. Yes, let's revise all the anatomy session with this quick revision. What are the questions going to ask from the general anatomy? During the class, I told you the 3 CBI magics. They were related with the intermuscular spaces, boundaries, contents, muscles and nerve supply, and then muscle, joint, and the movement. Directly, indirectly, it is going to be applied. Either they will be directly asked from the anatomy or the surgery, medicine, ENT, ophthalmology, obs-gyn, any subject, but it is going to be useful. Next, mark my word, one question directly, indirectly from the joint. Suppose no direct question from the joint, but orthopedics is depending on the joint and the bones. So get ready for this joint topic. Yes, parts of the bone and tumor arising from it. Yes, I taught you the epiphysis, diaphysis, metaphysis, and the growth plate of the cartilage. And the tumors are arising from here, for which I given the mnemonic demo ECG, osteosarcoma, the Ewing sarcoma. Yes, you have to read about the giant cell tumor and other many more bone tumor. One bone tumor and parts of the bone, they are going to ask. Dermatome. Actually, the dermatome and the vertebral levels, they are not the part of the general anatomy, but I have to keep it at any segment. Dermatome of the body and the any important vertebral level. It is the favorite topic of the INI-CET. So don't miss it. Okay, vertebral level, they ask about the ischial spine. They ask about the any particular. We had seen the magic of the C1, C2, C3, C4, C5, C6 at the palate, pharynx, larynx level. Okay, also at the thoracic vertebra and the lumbar vertebra, the different planes are there. So get ready for that topic. Okay, dermatome, entire body, but dermatome is important. So look for this. Next, in the head neck portion, definitely the cranial nerves are going to ask the most important cranial nerve which you have to study, that is the facial nerve, then trigeminal nerve. Also, you have to look for the 11th nerve, 10th nerve, and don't forget the ophthalmology nerve, the third, fourth, and the sixth, and the optic pathway for the physiology also. So this is the sequence. The most important cranial nerve, sir, facial and the trigeminal, according to the view of the anatomy. Yes, definitely one question from the skull and the cranial foramen they are going to ask. So I told you the one funny mnemonic: king, queen, and king is giving rose to the queens. So don't forget it. It will be useful. Muscles of mastication is a lovely topic. It is related with the pharyngeal apparatus also. So you have to prepare it. Larynx nerve supply. It is related with the anatomy. Yes, ENT, medicine, surgery, as well as the radiology. So don't forget this: internal laryngeal, recurrent laryngeal, the external laryngeal nerves. Sir, the face, the facial muscle expression, the arteries of the face, the 8 branches of the external carotid artery, and the nerves of the face. Again, the facial nerve and the trigeminal nerve, they are important. Triangles of the neck, directly, indirectly, the triangles of the neck, they will be asked. Yes, it will be useful in the surgery of the submandibular gland. Yes, you can say the parotid gland, thyroid gland also. Glands integrated with the surgery. So definitely one question either from the parotid surgery or the submandibular gland surgery or the thyroid surgery is going to ask in your exam. In the neuroanatomy section, no excuse with the brain section. Yes, you have to prepare it with the integration to the radiology and the functional area of the brain. You have not to miss this topic. We had seen in anatomy with integration to the medicine, stroke, and the transient ischemic attack also. Yes, white matter of the brain like the corpus callosum and the fornix, as well as the different tract, they are important. I taught you the ACP, association fiber, commissural fiber, and the projection fiber. Yes, one question may be asked from here. Basal nuclei and the Parkinson is very important. I told you the son create problem, daughter never create problem. Parkinson and Wilson, they are important. And one question sure from the cerebellum. I taught you the MPG, molecular layer, Purkinje layer, and the granular layer. Also, I taught you the Bahujan Samaj Party joined by the Goga Sir G, our respected Goga Sir G. Yes, so we had seen the basket neuron, stellate neuron, Purkinje cells, granular cells, and the Golgi cells. So get ready for here. One neuron if you want to study, then don't miss the Purkinje cells, Purkinje neuron. Next, the blood supply of the brain and the head and neck phase is very important. The circle of Willis, the 5 branches of the circle, 5 components of the circle of Willis, 5 branches of the internal carotid artery, 5 branches of the vertebral artery, and the 5 branches of the basal artery. I taught you the magic of 5. Also, don't miss the blood supply of the head and neck phase. Next, the cranial nerve nuclei and the brain stem syndrome. Right now, in your NEET PG and the INI-CET, again, that gusse, be, gue, gua, ba, gussa, and sasa. Do you remember this beautiful concept, beautiful mnemonic? Yes, get ready for this topic. Otherwise, the cranial nerve nuclei and damage to the cranial nerve nuclei, it will result into the different brain stem syndrome. It is going to ask in your exam. Maximum 50% of the question in the INI-CET, they are going to ask from the head neck phase and the neuro portion. Remaining 50% of the syllabus, they are going to ask from the upper limb, lower limb. Yes, head, you can say the abdomen, pelvis, this portion. Okay, so in the upper limb, don't miss the nerves of the upper limb as well as the clinical integrated to the orthopedic surgery and the medicine. Yes, in the similar way, the breast and the breast surgery is important. That's why you have not to miss the pectoral region, especially with the cadaveric image practice. Also, the short intrinsic muscles of the hand. Yes, lumbrical, palmar interossea, dorsal interossea, with its action now supplying the clinical is important. Yes, any muscle and movement, they will give any tabular form and they will ask to match them. Okay, so don't miss this muscle and movement of the upper limb portion. Now look for the important topics of the lower limb. In the lower limb, the most important topic is nerves of the lower limb as well as its clinical integration. So don't miss the sciatic nerve, the common peroneal nerve, the superficial peroneal nerve, the tibial nerve especially. Also, you have to look for the superior gluteal nerve and inferior gluteal nerve. Nowadays, they are asking also about the lateral cutaneous nerve of thigh because its compression is leading to one important clinical condition, that is a meralgia paresthesia. Next, always during the class, I told you the gluteal region is very important. The INI-CET people, they love the gluteal region. So you have to look for the gluteus maximus, medius minimus with its clinical, like the Trendelenburg sign, like the lurching gait and the waddling gait. Yes, and no excuse with the arteries and the veins of the lower limb because of the peripheral vascular diseases of the lower limb, the thromboangiitis obliterans, as well as the varicose vein, as well as the deep venous thrombosis. You have to look for the topic of the, yes, arteries and the veins. In the similar way, in the lower limb, they can ask any particular muscle and their movement on the base of the cadaveric image. Also, the foot and its different kind of deformities, the foot and its movement, like the inversion, eversion, flexion, extension can be asked. Yes, arches of foot is important due to the congenital talipes equinovarus and different kind of the foot deformities. Yes, also sometimes the foot ligament as well as the different kind of the foot arches are asked. Now come to the next. Look for the thorax. Very limited topics are asked from the thorax. Sir, nowadays in INI-CET exam, they are asking the integrated radiology with the anatomy. Yes, they will ask the transverse section of the thorax at any particular vertebral level. They will mark and they will ask to identify that structure. As well as integrated medicine, you have to look for the heart blood supply, arterial supply, as well as the venous drainage. Arterial supply is more important. Yes, you have to integrate this topic with the myocardial infarction and the angina. Definitely in medicine, one question from the MI angina is going to ask. Yes, the topic, the discussion will start from the heart blood supply, as well as intercostal space you can have to see for once. And in histology, they will ask about the respiratory tree, especially they are asking the respiratory bronchiole and the terminal bronchiole. In abdomen portion, yes, INI-CET people, they love the peritoneum and the peritoneal ligaments, as well as one more topic related with the peritoneum, that is a greater sac, lesser sac, and the communication between the greater and lesser sac, that is the epiploic foramen, integrated with the Pringle's maneuver. Yes, this peritoneal ligament, they will be asked integrated to the surgery, like the gastrosplenic ligament, like the linorenal ligament, like the phrenicocholic ligament. Yes, such kind of the ligaments are important because within it the blood vessel is running, so useful for the surgery. Next, diaphragm and hernia. During the class, I taught you in our body there are the total 8 diaphragms, and whenever there is a diaphragm, there is a chances of the hernia. So the most important diaphragm is the thoraco-abdominal diaphragm. Other diaphragm which they can ask, that is the pelvic diaphragm, the urogenital diaphragm, yes, the Simpson's fascia, that is the diaphragm between the neck and the thoracic cavity. So you have to look for it. Next, the blood supply, the GIT, you have to know the foregut artery, celiac trunk, the midgut artery, supramesenteric artery, and the hindgut artery, that is the, yes, inframesenteric artery. So remember, the blood supply of the GIT is very important, especially integrated to the surgery, medicine, other subjects. Also, the branches of the abdominal aorta you have to learn, which we compared with the Bahubali and Devsena diagram. So branches of the abdominal aorta, the ventral branches, the lateral branches, yes, as well as the terminal branches, and the only one median branch you have to learn. Next, the pelvis. So pelvis topic, it has been shifted to the surgery and obs-gynae part. What are the important topics? Sir, prostate, the BPH and prostate cancer, they are common. That's a one question from the prostate definitely going to ask. Yes, urethra rupture is very common in the clinical scenario. So you have to learn about the parts of the urethra, also the cadaveric images with the radiological integration, and bulbar and membranous urethra rupture. Yes, rectum and anal canal, they are important for the anal fissure, anal abscess, and piles region. That's why the basic anatomy things you have to know. Pelvic diaphragm is very, very interesting and very, very lovely topic for the INI-CET question. So don't miss this pelvic diaphragm for the INI-CET. Branches of the interiliac artery, yes, the anterior division, the posterior division. The anterior division will supply the pelvic viscera, that is important, and the posterior division, I told you the mnemonic, I love Sunny. I for iliolumbar artery, L for lateral sacral artery, and S for superior gluteal artery. Remaining all are the branches from the anterior division. So it is important for the obs-gynae purpose also, genitourinary surgery purpose also. Now come to the embryology section. Sir, nowadays in the INI-CET, the INI-CET people, they are asking the spermatogenesis, oogenesis questions again after a long break. Okay, germ cell layers. Yes, germ layer, you can say the endoderm, the ectoderm, the mesoderm. Their different germ cell layer. What is the sequence of the formation and what are the other derivatives of this layer? That is important. Neural tube development is very important, as well as neural tube defect is important because it is integrated with the anatomy, the biochemistry, yes, surgery, medicine, pedia, as well as the obs-gynae. Yes, neural crystals derivative. So I told you one very interesting mnemonic: pits doing disco in front of the Man Mohini Mallika, because neural crystals derivative, if they are not reaching to their location, in that situation it is causing the loss of the diseases. That's why the neural crystals derivatives is important. And pharyngeal apparatus, mark my word, one question directly or indirectly integrated to the ENT, surgery, medicine, or radiology, it is going to ask. Yes, the pharyngeal arch artery is also very, very lovely topic for the INI-CET question. And one more thing I want to add, the cardiovascular system development, not directly it is going to ask, but integrated to the pedia and medicine. I taught you how the heart is developing, as well as the truncus arteriosus is getting partition. If there's a problem, then how the tetralogy of the phalloid, how the truncus arteriosus disease, how the transposition of the great arteries, and many, many diseases are occurring. That topic is important. And at the end, what topic you have to focus for the histology? Yes, if you know the histology, then you can easily understand the pathology slide. So you have to look for the epithelium. Yes, you have to look for the glands. Especially in INI-CET, they are asking the merocrine, apocrine, holocrine. But nowadays, they are also focusing for the paracrine and the autocrine glands. Yes, which gland histology individually you have to see. So adrenal is very favorite question for the INI-CET. Also the pancreas, parotid, submandibular gland, and thyroid gland histology you have to look. Also, you have to look for the cartilage. Yes, collagen and collagen disorder. Yes, connective tissue disorder like the rheumatoid arthritis, systemic lupus erythematosus, systemic sclerosis. Many disorders are there. They are derived due to the abnormality in the collagen. That's why you have to look for the collagen histology. And at the end, skin histology is very important. One more thing I want to add, that is the lymph organ, lymphatic organs histology is also important. So these are the things which you have not to forget. So at the end, dear friends, all the best. God bless you all. If you can change your mind, you can change your life. So remember, you prepared very nice. Don't get fear. Yes, be cool, calm, relax. And there will be the 4 options. 2 options you can rule out. Be confident and mark one option as your best answer. Trust on yourself. Trust on the God. Trust on your teacher. Trust on the your notes. You will win. All the best. God bless you all. Remember, आदमी या तो जीतता है या फिर सीखता है. आदमी हारता कभी नहीं है. आदमी हारता उस दिन है जिस दिन वो कोशिश करना छोड़ देता है, कि वो डरे जिंदगी से कि क्या होगा. अरे कुछ नहीं होगा तो कम से कम तजुर्बा होगा. All the best. God bless you all.
Hello everyone, I'm Dr. Pooja, your own Physiology faculty, and today we are going to discuss about the INI-CET pre-exam session or pre-exam questions. What we are going to do in this, you all know that we are going to do the anticipatory control. We're going to anticipate the questions that are going to come from the specific topics. So I will be anticipating the topics and what type of scenarios they can ask you. These are the examples that you have to be prepared for. So let's start with the first question. Which of the following transport mechanism requires ATP? So transport across the cell membrane is the first topic you cannot miss before going to the exam, right? So what they are asking over here is requires ATP. You know that if they are showing the arrows like this, see over here, from low concentration to high concentration, going against the concentration, it will be required the ATP. Now see over here, it is the round shape facilitated transport, because they have not shown the gradient over here. So I'm assuming this must be the facilitated transport. And facilitated, we know that there is requirement of a carrier protein, but no requirement of ATP. So I'm not going to go with that. Next is the paracellular transport. You can see this is the one cell, this is another cell. Something is going in between from the periphery of the cells, sideways of the cell, and it is none other than your paracellular. Paracellular also does not require any ATP, right? Next comes here. Gate is open, gate is closed. What is this? This must be a channel. Remember, channel is a simple diffusion. But ma'am, you are showing the protein also. This protein is not changing the configuration like this. They are not changing its structure. Just the gate is opened and closed. Please remember, it is simple diffusion. Channel comes under simple diffusion. So I'm going to mark it as option C. So you have to first of all identify what type of transport it is and whether it requires the ATP or not. All right. So that is the question. So see over here, they can show you the vesicular transport. Vesicular transport requires the ATP no matter whether it is going along the concentration or against the concentration. Vesicle formation requires energy. So yes, if they would have shown this exocytosis, endocytosis, what is this? This is exocytosis, this is endocytosis, and this is going through and through the membrane across the cell, you can say. So it is a transcellular transport, right? So this is simple diffusion, facilitated diffusion. This must be again simple diffusion, no carrier protein required, and it is going along the concentration gradient, right? This must be the channel going from high concentration to low concentration, again simple diffusion. And this ABC below, that will be requiring the energy, which is vesicular transport. Now, the next most important topic is going to be your sarcomere and EC coupling, right? The sarcomere, I have given the structure over here, and rather than asking the structure, I have asked over here the property that it gives. So you have to first of all identify. See, either they are going to give you this type of image or they are going to give you this type of image. You have to identify what is it, right? The dark band, you have to first of all notice the light bands. Light bands are nothing but the I band, and in between the I band, you're going to have the Z line over here. So this must be Z line, and between two adjacent Z line, you're going to have the M line over here, right? And this must be the myosin. The thicker one is going to be the myosin, which must be overlapped with some of the actin. So I can say from here to here, I have A band, and this over here is I band. This is I band, this is I band. Okay, in between I have Z line. So now what protein they have shown over here is labeled as X. So what is labeled as X? You can see something is going from the Z line to M line. You can see something is going from the Z line to M line. What must be this? Z to M, yaad rakhna, this is none other than your titin molecule. Titin molecule, which is a spring-like structure. Spring. Why I have shown the spring? Because remember, it is acting as a muscle spring that gives the recoil property. When you stretch a muscle, it will come back to its normal position. When you compress a muscle or overlap it too much, again, when you want to relax it, it will come back to its resting position. Returning back to its normal position is recoil. Plasticity. Please remember, plasticity, when the titin is absent, that is going to give the plasticity which is present in the smooth muscle. They have shown over here the sarcomere in the skeletal muscle. Compliance. Does the compliance is given by this titin? It helps to give the compliance, but remember, it resists the compliance. It resists the change. It wants to return back to its normal position. I'm not going to choose that, right? Recoil property, yes, it gives the recoil property. What about contractility? Contractility will be given by mainly the actin and myosin. These are the contractile protein. They have not shown the actin or myosin by X, so I will not mark this. All right. So please identify it correctly. What are the other type of scenario they can ask you? They can ask you to sequence it from the periphery towards the center, or from the center towards the periphery, or they will give you label it like A, B, C, D, like that, and you have to identify what is the structure, right? Suppose A they have given, so they will be giving it as from here to here, so that will be A band, M line, Z line, or I band, right? These type of structures they can ask you to identify. Next question. Action potential is given, and what is they're asking? Seminar was presented, right? Ion channel responsible. We have to find out. Ion channel opening primarily responsible for phase 0. Now, multiple times I have told you that phase 0, agar pucha directly, they can either ask you this phase 0, or they can give you the arrow like this and identify which ion is responsible for this upstroke or this phase shown by the arrow. Now you have to identify this is nothing but the depolarization. Please remember, phase 0 is depolarization, phase 4 is the RMP. Don't get confused there. Phase 0, we know the funny cat pick. I told you how to identify what type of action potential it is. There are 2 hints which will be given in the images, right? Whatever type of image, whatever type of graph they are going to give you, first thing you are going to do, not to get scared, look at the X and Y axis or find out some clues into the image itself. See over here on the Y axis we have minus 60 millivolt. That is nothing but the potential. From minus 60 to minus 40 is the RMP of nodal tissues or the pacemaker potential, isn't it? So that means this must be the pacemaker potential ka action potential. First of all, I have to identify that. Funny cat pick, that is The pacemaker potential phase 4 will be because of the sodium calcium T channels and potassium immediate closure. But they have asked about phase 0. Phase 0 is not dependent on the potassium. Potassium will be responsible for repolarization. T type of channel will be responsible for phase 4, that is RMP, autorhythmicity. L type of channel, long acting calcium channels, will be responsible, and hyperpolarization activated cyclic nucleotide gated channels. These are nothing but your sodium channels, which again, hyperpolarization activated Jesse Bola. You have to know that they are asking about the pacemaker. That is nothing but phase 4, which is the slope over here. So the answer over here is going to be option C. Next, fetal hemoglobin. Now, this is one of the type of scenario I have just taken as an example. They can give you, see, last time they have asked about stored blood. I don't think so they are going to ask again about the stored blood. Either they are going to ask you about the carbon monoxide poisoning, methemoglobinemia, fetal hemoglobin, less 2,3 BPG, and all these things. Or they will ask you, in one column they will give you the scenarios, and in another column they will give you left shift, right shift, and you have to match with it, right? So that can be given in the INI-CET. Over here, what is asked? Fetal hemoglobin. You know that if it is a right tag, that means tag is increasing, the right shift will be there. What is tag? If the temperature is increasing, second, acid, any type of acid is increasing, glycolysis or 2,3 BPG is increasing, all these things are going to cause the right shift. All other rest of the things are going to cause left shift. Be careful about the pH. When you increase the acid, pH decreases. When you increase the carbon dioxide, oxygen partial pressure decreases. Alright, so hypoxia and increase in the pH also causes the right shift. That is going to be there. Alright, so they can ask you about the exercise, they can ask you about fetal hemoglobin, they can ask you about increase in the temperature or any other scenario. You just have to remember the famous mnemonic, right tag. Okay, please mark it correctly. Next question. Particularly in the detection of low frequency. So 60-year-old man came with the sensory deficit. And what is the deficit? Low frequency vibration. He is not able to identify that. Right. So, and the fine textural variation upon tactile examination. I told you first thing first. When they say tactile examination, and look over here, Merkel's, Meissner's are given. Wala receptors are going to be responsible for touch sensation, tactile sensation. But if I ask about low frequency vibration specifically, or I can say slow frequency vibration, then it will be Meissner's and Meissner's only, right? If they ask best for 2-point discrimination, blind mein, braille reading mein, who helps? Or if they ask static 2-point discrimination, then only you are going to mark it as Merkel's. Otherwise, all other options for the 2-point discrimination also and fine touch also, it is going to be your Meissner's. All right. So that is going to be the receptor which is going to be compromised. Over here, why I have put up this question? For last 4 years, continuously they're asking one question from somatosensory receptor. You cannot miss the topic, and you cannot miss revising it just before going to the exam or one night before. Just matha tek ke zarur jana. All right. Let's move on to the next topic. Again, one question for sure is going to come from metabolic acidosis or alkalosis or respiratory acidosis, alkalosis. That is nothing but the acid-base disorder. You have to know about this. What we do in this, as soon as I know that options are talking about acidosis, alkalosis, I'm going to see first thing first is going to be the pH. What is the normal pH? 7.35 to 7.45. If the pH is lesser, it is acidosis. If the pH is more than that, it will be alkalosis. pH over here is 7.12, which is lesser than 7.35. So I'm sure this is acidosis. One option is already out. See over here, plasma PCO2, that means the partial pressure of carbon dioxide, which is a representative of the respiratory acid, isn't it? So it is the respiratory acid. What is the normal value G? 35 to 45 mmHg. Now see over here, the acid is increasing. Acidosis is there. For sure, my respiratory system in the patient is compromised. Respiratory acidosis patient is having. Next, bicarbonate concentration is 19 milliequivalent per liter. What is the normal value G? 22 to 26 as per the physiology books, 28 as per the medicine books, right? So even if I take it as lowest margin 22. It is lesser than the lowest margin. So what you can see, the acid is also increasing and the buffer is also decreasing. The both systems, the renal system as well as the respiratory system, both of them are compromised. I'm going to go with the mixed acidosis. I'm going to go with the mixed acidosis because both are there. So I cannot just take the respiratory or metabolic. I'm going to go with the mixed acidosis if both the things are compromised. So look at the pH first. Look at the changes that are occurring in the PCO2 and the bicarbonate. Bicarbonate is metabolic buffer or alkali. You have to remember that if you increase the alkali and increase the acid, if they would have given over here, let's say, assume 28, what I will do? I will go with the PCO2. That means it must be the respiratory acidosis case. In this scenario, if they give the bicarbonate as 28 and vice versa, if the acid is low, PCO2 is low, but the bicarbonate is also low, then I'll go with the metabolic acidosis. Let's move on to the next question. Match the following hormones with their receptors or their pathways. Continuously they're asking this, be the NEET, PG or INI, you have to know about this receptor and their pathways and the hormones. All right. So V1, I told you, if it is looking like V1 or alpha 1 or let's say the M1 receptor in the acetylcholine, then it is going to look like I, right? So I'm going to mark it like the IP3DAG, IP3DAG, GQ proteins. This is going to work with, right? And this is going to look like I. So it will be the IP3DAG. So I'm going to mark it as A2. Insulin, we all know piglet, right? What is the piglet? C dirty piglet. C dirty piglet was C. That means the cytokine kinase. Dirty was tyrosine kinase. Piglet was prolactin, insulin, and growth hormone, growth factors, and leptin. All these are going to either work through cytokine or going to work through the tyrosine. So prolactin, we all know it is going to mainly work with the cytokine receptor. Cytokine receptor is not mentioned. So see over here, what else is mentioned? JAK-STAT pathway, I told you. Prolactin, the growth hormone, and the leptin. They are going to either work with the cytokine kinase, and the pathway if they give, it is going to be JAK-STAT pathway. So prolactin is going to be paired with the number 4. The M2 receptor, they are going to act through the GI protein, which decreases the cyclic AMP. So I can mark it as 1 over here. ANP is going to work. ANP, NO. If ANP and NO is there, cyclic GMP. So what is there? 1,2,B3, 1,2,B3, C1. So this is going to be E5. All right. So option D is going to be the answer over here, which is matching with that. All right. Even if you know 2 to 3 things, you will easily get to the answer. All right. So these receptors, this topic is very, very important. Please remember that. They are asking thyroid specifically. They have asked last 2 exams. So we are not assuming that they are going to again ask you about thyroid, but thyroid is going to act through the T3, T4. They are going to act through the nuclear receptor. Remember that. Which of the following decreases GFR? My dear friends, you cannot miss this topic. Decreases GFR. I told you one thing you have to remember. They are going to ask you about decrease or increase. Suppose this is the capillary, glomerular capillary, Bowman's capsule, right? And if I say the hydrostatic pressure, which is the pushing pressure, if the pushing pressure is increasing over here, the GFR increases, right? But the holding on pressure, that is oncotic pressure, increases in the Bowman's capsule. Again, the GFR increases. But please remember, if I increase the hydrostatic pressure over here, how the hydrostatic pressure can be increased? There must be some calculi in the ureter. Ureter has the calculi, but it is putting the back pressure on the collecting duct. It is putting the back pressure on all the tubules, including the DCT, loop of Henle, PCT, and then they are going to put the back pressure on to the Bowman's capsule, which is going to have the high hydrostatic pressure. Definitely the GFR is going to decrease. They have not given the direct option over here as increase hydrostatic pressure, but they have given the ureteric calculi. If you increase the renal plasma flow, the hydrostatic pressure inside the glomerular capillary, that is going to increase. In one of the exam, they have given coefficient of filtration. नाम में ही है ना, coefficient of filtration. The name itself telling you filtration coefficient is increasing. G filtration must be increasing, right? Decrease in the glomerular capillary oncotic pressure. If you decrease the glomerular capillary oncotic pressure, GFR increases. The holding on pressure has been decreased, so GFR increases. Increase in the glomerular capillary hydrostatic pressure, again the GFR increases. Either they're going to give you the scenarios or they're going to give you directly increase or decrease in particular stalling forces. You have to identify this. All right. So what are the other topics that they're going to ask you? These are the crucial topics. Please take a screenshot of it, and please, one night before, rather than getting anxious, just look over these topics and you are good to go in physiology. Just apply your brain, be calm, and all the very best. Thank you so much. That is from my side. Thank you very much.
Hello friends, will you all the best for your exam. Now we discuss important topics for INI. First, ectodermatitis enteropathica. It is autosomal recessive disorder in which there is defect in the zinc absorption in intestine. So zinc deficiency would be there. There would be diarrhea, dermatitis, and dermatitis is acral region, periorificial, tip of finger, around nose, mouth, anus, cheek, etc. Yes, you can find the image-based question also. Diarrhea, dermatitis, periorificial acral region, zinc deficiency. But if diarrhea, dermatitis, dementia, then it is pellagra. In pellagra, there is typical sun-exposed area, dermatitis present, just like castle neck appearance, you may find in the question. Zinc deficiency, mnemonic is hide, H for hypogonadism, H for healing, delayed wound healing, immunity, decrease immunity, diarrhea, D for diarrhea, dermatitis, and in this alopecia is also there. Inhibitor of complex electron transport complexes, complex 1, name itself tells you ONE1, rotinone, phenobarbital, amobarbital, aldehyde. Aldehyde is present at carbon number 1. Piercidine, if you pierce ear with the help of needle looking like 1 or A, first alphabet, you may remember. Complex 2, inhibitor malonate, mnemonic was MS Dhoni, MS Dhoni. दो नहीं रहेगा, complex 2 is inhibitor, and succinate dehydrogenase is also inhibited by malonate, and malonate or malonyl coenzyme also inhibit CPT1. Okay, carboxin, carboxin or carbi मतलब 2. Okay, TTFA, TT, yes, you can modify it and it looks like second complex inhibitor 2. Complex third inhibitor N3-mycin, N3 complex third, British antilucide, BAL. So 3 letters, complex third. Complex 4, you will find ide, azide, hydrogen sulfide, cyanide, carbon monoxide. So all have ide, but not nitric oxide, not NO. NO is the vasodilator, and it's not inhibitor of complex 4, recently asked question, and it synthesized from arginine, NINE, 9, name itself tells you 9, matlab no. Okay, yes, arginine is going to NO. Benedict test is positive in these 4 disorders. Questions are asked. Yes, minor type of galactosemia. In this, galactokinase is deficient. And in this, only and only cataract, oil drop cataract is present. Classical galactosemia, galactose 1 phosphate, uridyl transferase is deficient. In this, oil drop cataract would be there, and fasting hypoglycemia, hepatomegaly would be there. There would be relation with breastfeeding, and breastfeeding is absolute contraindication. Symptoms occur early in life. This point is important to differentiate it from hereditary fructose intolerance, in which aldolase B is deficient. In this, cataract would not be there. In this, relation would be with fruit juice. Symptoms start around 4 to 6 months when you start weaning. Yes, exclusive breastfeeding up to 6 months, very much. Okay. So when fructose will come in diet, these symptoms will appear, and essential fructosuria, fructokinase deficient patient is asymptomatic. All these 4 Benedict tests will be positive. Next topic, hyperlipoproteinemia, very important. Hyperlipoproteinemia type 1 or familial hyperchylomicronemia. In this, the defect is lipoprotein lipase or ApoC2. You know, ApoC2 is activator of lipoprotein lipase. If lipoprotein lipase or ApoC2 is defective, then it is type 1. In this, chylomicrons are increased. VLDL also increased, but chylomicron increases more. That's why it is also called familial hyperchylomicronemia. Chylomicron and VLDL contain mainly triglycerides. So triglyceride increase, cholesterol is normal or near normal. And triglyceride is increased, there would be, yes, cream of tomato soup appearance, milky white plasma. And if you keep the sample at 4 degrees centigrade, there is supernatant layer of white color and eruptive xanthoma would be there. Type 2A, defect in LDL receptor ApoB100. LDL is increased, LDL contain cholesterol, triglyceride would be normal. So this is familial hypercholesterolemia. In this, there would be increased cholesterol, so chest pain, coronary artery disease, and patient present with tendon xanthoma or tuberous xanthoma. Type 3 itself tells you E, ApoE is defective, and ApoE is required for the metabolism of remnant. Chylomicron remnant, VLDL remnant are not metabolized. Remnant contain both cholesterol and triglyceride, so both triglyceride and cholesterol are increased. So cholesterol increase, tuberous xanthoma, triglyceride increase, eruptive xanthoma, tuberoeruptive xanthoma. Yes, looking like grapes, bunch of grape, and there would be palmar xanthoma. If you see the palm, it looks like E. Okay, crease of palm looks like E. So ApoE is defective. Sphingolipidosis, lysosomal storage disease, commonly asked Tay-Sachs disease. Mnemonic is TSH. Tay-Sachs hexosaminidase A is deficient, and this is GM2 gangliosidosis. T42 GM2 gangliosidosis. In this, there would be red spot, neurological symptoms would be there, no hepatosplenomegaly. Question T4 tiny organs. T4 tiny organs, no hepatosplenomegaly. Niemann-Pick disease, neem soap, mnemonic neem soap, sphingomyelinase is deficient. And if you take a bath with neem soap, you will find bubble or foam. Yes, not just like, Nirma girl, but yes, you are taking bath after so many days, so hazy bubbles. Okay, and zebra bodies, you may remember simply by mnemonic that if you take zebra and wash this powerful soap of neem, all stripes will go. This is a hypothetical story. Okay, Niemann-Pick, Niemann-Big, big hepatosplenomegaly would be there. So cherry red spot present in both Tay-Sachs and Niemann-Pick disease. Neurological symptoms present. So how you will differentiate between Tay-Sachs and Niemann? Very simple question. Yes, hepatosplenomegaly present, that is Niemann-Pick. No hepatosplenomegaly, Tay-Sachs disease. Commonly asked. Goucher disease, gouge, ouch, bone pain. A girl is crying. You gave tissue paper. What she will do? Crumpled tissue paper appearance, and you will remember the meme. Yes. आंसू मैं पूछूं और yes. So bone pain, crumpled tissue paper appearance, beta glucosidase deficient or glucocerebrosidase deficient. In this, thrombocytopenia, hepatosplenomegaly would be there. No mental retardation or neural symptoms would be there. No cherry red spot. Okay. Krabbe's disease, beta galactosidase deficiency or galactocerebrosidase deficiency. In this, globoid cells are there. No hepatosplenomegaly, point it out. Neurological symptoms, cherry red spots may be present, so plus minus. Okay, this point is important because you can't make the diagnosis on the basis of cherry red spots. Enzyme inhibition, competitive inhibition, Km is increased, affinity decrease, Km increase, V maximum remains same, and competitor cut each other, mnemonic, so they are meeting, cutting, they are cutting. So wherever you find the cutting each other, yes, that is competitive. Non-competitive, no change in Km. Name itself tells you non-competitive, no change in Km. V maximum is decreased, and in this you will find V. Now you have no competition, you have won, sign of victory. This is V, and this is again V with erectile dysfunction. Uncompetitive U, if you write inverted U, both Km and V maximum decreased. And if you find the image based question, you can easily solve. Yes, if you make U from these two parallel lines, or this is looking like U, you can easily find U in the graph. So answer is uncompetitive inhibition if you find U. Phospholipids, on which question has been asked. Phosphatidylserine, marker for apoptosis. Phosphatidylcholine खोल के रखेगा ये lungs को. Yes, lecithin if deficiency, respiratory distress syndrome. Okay. Cardiolipin in question. Cardiolipin is present at inner mitochondrial membrane. It is having antigenic property. CAR-BAR, Bath syndrome, cardiolipin defect, and in this cardiomyopathy would be there. On glycolipid, question has been asked, GM1 ganglioside act as receptor for cholera toxin in intestine. Repair mechanism, defect lead to which disorder? नॉन होमोलोगस एंड ज्वाइनिंग, नो होम. जो सीआईडी पर्सन होते हैं, रो एजेंट होते हैं, सीआईडी रो एजेंट. यस, टाइगर मूवी वाज Salman was not having any home. Now I do remember with Dhurandhar, no home, but he was happy. Yes, उसके पास, सलमान के पास तो कैटरीना थी, he was happy. Okay, so anyways, so CID, no home. Home, we people at home, what we do? आटा, तेल, ataxia, telangiectasia. निज मैगन, अपनी मैगी ब्रेक करके बनाओ, निज मैगन ब्रेक सिंड्रोम. ब्लूम, ब्रूम, झाड़ू लगाओ. वर्नर, बर्नर पे चाय बनानी है. रोथमुंड, यस, मूड नहीं है तो रोटी भी बनानी पड़ेगी, वाइफ का मूड नहीं है तो. ब्रेस्ट कैंसर ससेप्टिबिलिटी, ये सब घर की ही चीजें अच्छी होती है, बाहर नहीं जाना बच्चों. न्यूक्लियोटाइड एक्सचेंज रिपेयर डिफेक्ट लीड टू जीरोडर्मा पिगमेंटोसा, कोकाइन सिंड्रोम, trichothiodystrophy, mnemonic is try, 0 calorie coke. Yes, trichothiodystrophy, 0 pigmentosa, cocaine syndrome. Spelling थोड़ा change है, but क्या करूँ, नोटी हो गए हैं. Yes, so we know that ultraviolet rays produce thymidine dimer that is corrected by nucleotide excision repair. If it is defective, lead to xeroderma pigmentosa. Patient present with skin rash, blister on some exposed area, susceptible to skin cancer. Okay. बेस एक्सिजन रिपेयर, तुम्हारी बेसिक पावर तुम्हारी मुट्ठी में ही है, MUTY एसोसिएटेड पॉलीपोसिस. ओके. मिसमैच, यू ऑलवेज ड्रीम कि मिस आएगी और वो लंच बना के लाएगी, ऐसा कभी होता नहीं है, रेयर होता है मेडिकोस. यस, सो लिंच सिंड्रोम. ओके. नॉन हेरिडिटरी नॉन पॉलीपोसिस कोलोरेक्टल कैंसर, डिफेक्ट इज मिसमैच रिपेयर. फ्रीक्वेंटली आस्क्ड क्वेश्चन, ट्रिप्टोफैन, 60 milligram of tryptophan give rise to 1 milligram of niacin, and in this pathway 3-hydroxyquinoline is produced. This is coming to niacin with the help of B6. If B6 is deficient, then quinoline will be coming to xanthonic acid. Recently asked question, in B6 deficiency, quinoline pathway is diverted towards xanthonic acid. So B6 deficiency, xanthonic aciduria would be there. Niacin deficiency, B3 deficiency lead to pellagra, diarrhea, dementia, dermatitis, and in question many times you will find that maize as staple diet. And if pellagra-like symptoms are there, yes, and they gave that HIA level, 24-hour urinary HIA level is increased, that is carcinoid syndrome. So carcinoid syndrome patient also present with pellagra-like symptom. So remember, pellagra-like symptoms given and HIA level is increased, that is carcinoid syndrome. Hartnum disease, autosomal recessive disorder in which there is defect in the tryptophan and neutral amino acid absorption in intestine and renal tubule. If tryptophan is not absorbed, definitely niacin will not be synthesized, so pellagra-like symptoms would be there. Name itself tells you, AR autosomal recessive, T for tryptophan, and U for neutral amino acid, P for pellagra-like symptoms. So if question they gave pellagra-like symptoms and amino acid urea is given, autosomal recessive disorder they have mentioned, so this would be the answer. Hartnum disease would be the answer. Okay. If pellagra-like symptom and they give xanthonic acid urea, so B6 deficiency, 6x xanthonic acid urea. So best of luck again.
So let's start with the first topic, which is selective estrogen receptor down regulators. So as the name tells, these are the drugs which will help in decreasing the number of estrogen receptors. So when receptors are less, estrogen will not be able to work. So they are used in treatment of breast cancer. So these drugs are used in treatment of breast cancer. And these drugs, the name end with ester, and the name you can remember is estrogen antagonist. Estrogen antagonist. The first drug in this category was fulvestrant, which is injectable drug given IM. It is first generation drug. Whereas later on we formed many drugs which can be given orally. So all other estrans can be given orally, like elacestrant and bepdegestrant, amlunistrant, camigide. So all estrans, they are estrogen antagonist, means selective estrogen receptor down regulators. Important thing, the first generation was intramuscular, all other are effective orally. Now, where they are best useful, they are used in that breast cancer where there is mutation in estrogen 1 receptor. So what happens is, normally for producing the action, estrogen should stimulate the receptor. Then estrogen will overwork, receptor will work. But when this mutation occur, receptor will work without estrogen. So there is no estrogen, still receptors are getting activated. So whenever this mutation is there, we will prefer estrogen receptor down regulators. Okay. So this is the first topic specific for INI-CET. Then moving to the next one, which is paroxysmal nocturnal hemoglobinuria. We all know it happened due to mutation in PGAG, and that mutation lead to overactivity of complement pathway. So what is happening in the alternate complementary pathway is, there is activation of C3 with the help of two factors, factor B and factor D. When C3 is activated, that will be broken down to C3, B and D, and this is basically overactivity of C3 will result in extravascular hemolysis. Occurs. Then when C3 is activated, it will activate C5, forming a membrane attack complex, and that will break into 5A, 5B, which will finally form membrane attack complex, and this will result in intravascular hemolysis. Yeah. So we have drugs which can stop this pathway, and that can be used to treat PNH, paroxysmal nocturnal hemoglobinuria. Traditionally, we had two main drugs, or we can say main drugs, which were targeting the complement factor C5. We commonly see the example of eculizumab. So eculizumab is saying that EC. C means complement, E means the fifth letter, A, B, C, D, E. So it is working on C5. Another drug is rabulizumab, and one more drug in same category is crovalimab. So all three drugs, they are inhibiting complement factor C5. But if you see that already extravascular hemolysis must have happened. So they are only used to control intravascular hemolysis, not extravascular hemolysis. So it was found that even after giving these drugs, some people develop extravascular hemolysis. So for them, we developed the another drugs which are targeting the proximal pathway. So we have drug which is targeting C3. Drug is antagonist of C3, and that drug is pegcetacoplan. And pegcetacoplan, again from the name you can remember, coplan look like complement. So it is a complement pathway inhibitor. And which complement pathway? It is saying as CE is C, T means 3. So CETA means CE means C and T means 3. So complement C3 inhibitor is pegcetacoplan. So what will be the advantage over eculizumab like drugs? They will inhibit not only intravascular but also extravascular hemolysis. Okay. Similarly, we have developed two more drugs. One which is factor D inhibitor, second which is factor B inhibitor. Drug which is factor D inhibitor is D for danicopan, D for danicopan, and the factor B inhibitor is iptacopan. Clear? So the three drugs, eculizumab, rabulizumab and crovalimab, they only stop intravascular hemolysis, whereas other drugs are inhibiting both intra and extravascular hemolysis. Okay, how HIV enters the CD4 cell? So if we stop that, the drug will be called as entry inhibitor. So what happens is, the first step for entry of HIV is, there is a glycoprotein on the virus called as glycoprotein 120 that bind to CD4 receptors on the CD4 cell. The first step is binding. So GP120 bind to CD4. After GP120 binds, there is conformational change in CD4. Now CD4 changes. Conformational change in CD4 receptor occurs, and when this conformational change occurs, what happens? Now it will activate a co-receptor. The second step is, when CD4 become active or conformational change occur, it will activate co-receptor, or we can say recruit the co-receptor, which may be CCR4 or CXCR5. So these are recruited. Now when they are recruited, then they will help in entry of the virus through a protein called as GP41. So glycoprotein 41, they will basically create a pathway. Glycoprotein 41 fuses with the CD4 cell and virus can enter inside. Clear? So revising, GP120, first step, bind to CD4 receptor. Second step, CD4 receptor get conformational change. Third step, that conformational change will recruit the co-receptor, that means CXCR4 or CCR5. And third, there will be recruitment of GP41 which will fuse. Okay, so if we stop any of them, we can stop the HIV growth, and the drugs will be called as entry inhibitor. entry inhibitors. And we have drugs for all of these conditions, these steps now. The first step was binding of GP120. So we have the drug which can inhibit the attachment through the GP120. So drug may inhibit GP120, and the name of the drug is fostemsavir. Fostemsavir. So this is inhibiting the first step. So if we see and speak like in Bengali language, so it will look like they're saying the first step. Fostemsavir means first step is inhibited. First step means first step, that means attachment is inhibited. Then second is post attachment. After it attaches, CD4 conformational change occurs. So the drug bind to CD4 and prevent the conformational change, and that drug is ibalizumab. So this is happening after the attachment. So the name ibalizumab says that it binds after attachment. It binds after attachment. Yeah. Then third step was to recruitment of co-receptor. The drug may bind to that and stop the entry. So the drug is maraviroc. And the name you can remember, Mara virus. That means virus is killed by binding to CCR5. Mara virus by binding to CCR5. And lastly, the drug may inhibit fusion by binding to GP41. And the drug which inhibits the fusion is enfuvirtide. The name tells everything. It says that the drug binds to envelope of the HIV. That means glycoprotein 41 on the envelope, and fusion of the virus with the T cell is inhibited. The name is telling everything. Bind to envelope glycoprotein 41 and fusion of virus with the T cell is inhibited. So these are the important HIV entry inhibitors. Okay. Then moving to very important topic. Currently these are in drugs, so likely to be asked, anti-obesity drugs. So orlistat we discussed several times earlier also. So it is oral, given orally, and it will make the intestinal lipase static. So inhibit the lipase enzyme. So fat cannot be absorbed. So when fat are not absorbed, they are excreted in the stools. So side effect is steatorrhea. Steatorrhea, fatty stools is the side effect. Then we have drugs which are incretin mimetic drugs, or we can say GLP analogs. GLP analogs. So till now we have mainly injectable drugs, drugs ending with tide, exenatide, semaglutide, liraglutide, tirzepatide. All of them are injectable drugs. Injectable drug commonly given subcutaneously. Now what is important is they are GLP analog. What is special about tirzepatide? It is a dual analog. It is not only GLP, but it is also GIP analogs. All of them are given injectable. Then we made a special preparation which is called semaglutide, special preparation which can be given orally. But for giving it orally, we need to give it with some absorption enhancer. Alone, we cannot give it orally. So we need to give it with some other compound which is absorption enhancer. But problem is we need to keep strict regulation. Like it should always be given in fasting. If a person takes meals in 30 minutes, the drug's absorption will be almost zero. Second thing, the drug should be taken with very less amount of water, less than 120 ml of water. So there are strict regulations on that. But very recently, we have developed a new drug which is called as orforglipron. Orforglipron is a non-peptide. All of them which are ending with the tide were peptides. So it is a non-peptide. So it can be given orally. It is also GLP analog. And it can be given orally. It do not require any special precaution. Just like a normal drug, it can be taken orally. So this is the newest drug which can be given orally for obesity as well as diabetes. It is orforglipron. The name says glipron means glutide-like drugs. Okay. Now quickly moving to some new FDA approved drugs, although they are not very important. So first drug we have just finished is orforglipron. So orforglipron, like other glutides or gliptins, so you can remember that these are the drugs which are GLP analog. But the name says or means it is given orally. Why orally? Because the name is not ending with the tide, so it is non-peptide. So this is the only first, or in fact only one non-peptide GLP analog we have. Then what is semaglutide? What is the advantage? Semaglutide oral preparation is available, but it is always given with some absorption enhancer, which the name is SNAC. The full name is sodium hydroxyaminocaprylate. No need to remember. So given with some absorption enhancer with strict precautions as we discussed earlier. No such precaution required for orforglipron. Then second, a special insulin preparation has been made, which is called as insulin icodec. Insulin icodec. So what is done is we have attached some fatty acid, icosanoid. You must have heard icosanoid, 20 carbon fatty acid. We have attached a fatty acid, ico means icosanoid fatty acid is attached to the insulin, which will make it highly albumin bound. So So when it is highly albumin bound, it will be removed from the binding site slowly. So it become very long acting. So it will decrease the release. Slowly it will be released. So we can give it once weekly. So this is the only insulin which is very long acting, can be given once in a week. Obviously given subcutaneously once in a week. And problem is, if you give overdose, so there will be hypoglycemia risk for 1 week. So risk of prolonged hypoglycemia if it is given in higher doses. Okay, so that is about insulin icodec. Next new drug is paltusotine. So paltusotine is nothing but somatostatin receptor agonist, stimulate the somatostatin receptor. But the advantage over octreotide or lanreotide like drugs is this is the oral somatostatin analog. Remember, octreotide is ending in the tide, means it is peptide. So it is a non-peptide drug. So it is oral non-peptide drug which is somatostatin 2 agonist, and that is used for acromegaly. We know somatostatin agonists are used in acromegaly. So new oral drug for acromegaly. Then next new drug you need to remember is a group called as cardiac myosin ATPase inhibitor. So basically they will stop the actin myosin interaction. So cardiac contractility decrease. So in which disease you want to decrease contractility? Yes, in hypertrophic obstructive cardiomyopathy. So whenever contractility occurs, outflow obstruction increases. That's why we avoid digoxin like drugs. So we use beta blocker in HOCM. So we can use the new drug in HOCM which decrease contractility. Their name end with CAM10. So mavacamten and a new drug aficamten. CAM10 means cardiac myosin inhibitors. Cardiac myosin ATPase inhibitors. So stop the actin myosin interaction. Okay. Then another very important new drug very recently approved is atripamil. Can you see the similarity with which drug? Yes, it is similar to verapamil. So like verapamil, it is L-type calcium channel block. Verapamil like drug, non-dihydropyridine calcium channel blocker, and advantage is unlike verapamil which need to give an oral or IV, this is given intranasally. It is given by as nasal spray and it is very fast acting. So it can be used for acute attack of PSVT. Remember, for acute attack we normally use adenosine. So now we have developed another drug which is atripamil. This can be taken intranasally, so no need to go to hospital. Person can take even at home. Adenosine need to be given at hospital. So that is a new drug, atripamil. Then we have another new anti-HIV drug which is isaltravir. So this is a new drug. Unlike NRTIs, which are nucleoside reverse transcriptase inhibitor, this has one dual action. Not only they are reverse transcriptase inhibitor themselves, but this drug also cause inhibition of translocation of reverse transcriptase. So translocation inhibitor as well as reverse transcriptase inhibitor. So the name is written as NRTTI. That means nucleoside reverse transcriptase and translocation inhibitor. So the name is saying that translocation of the virus is inhibited. So like other NRTIs, it is oral drug, but advantage is it is very long acting drug, very long intracellular half-life is there. It is approved for HIV and it is being tried for pre-exposure prophylaxis of HIV also. Okay. So these are the new drugs which have recently been approved. So these are the important things you need to remember for INI-CET 2026. Thank you very much.
Hi friends, I hope all of you are pretty much geared up for INI-CET exam taking place tomorrow. My best wishes for the same. I just wanted to have a look at certain important topics which may be asked in the exam. First one is going to be with regards to the topic of cell injury. You just need to have a quick recap about the different patterns of cell death and the salient features. From the topic of immunity, please do have a look at the pathogenesis, the reasons for the autoimmune disorders, the different antibodies which are seen, and the kind of images that are seen with respect to the specific IF patterns. The third is with regards to neoplasia, have a look at the different genes and their association with the different types of malignancies. Not to forget about the examples of the tumor markers which will be asked in the exam. The fourth and an easy topic asked in the exam is the topic of leukemias and lymphomas, wherein they ask you about the CD markers and the presentations. The next one is going to be with regards to blood banking with special emphasis on the blood and its products, the shelf life of the products, and it shall also include the different types of complications which may be associated with blood transfusion. Don't forget to have a look at the vacutainers, the kind of anticoagulants present in them and their typical uses in the clinics. The final one is going to be from the topics of the cancers, particularly lung cancer and renal cancer with regards to the specific findings in association with the different subtypes of each of these cancers. Right?
Not to forget, the last but not the least, we will need to have an idea about the important question which have already been asked in the exam pertaining to the histological finding, pertaining to the diagnostic finding in context of a tumor like breast cancer. All the very best from my side. I'm sure you're going to be doing exceedingly well in the exam tomorrow. Best wishes.
Hello, everyone, and welcome to the INI-CET pre-exam questions of microbiology. I am your faculty of micro here at Cerebellum Academy. I'm Dr. Devyani Puri, and let's begin with the first question. So, in the first question, so these are all the questions that I think are the probable topics that can come. Some are previous year questions or previous year topics. And what I feel is that they can ask you some little modifications of the questions. The topic can be the same, but they might not ask you the question directly. So here in the first question, we have a man with the long-term corticosteroid use who had fever, productive cough, and confusion, and now is coming with the cavitary nodules. Now, modified acid stain picture has been provided to you, and they're asking you the empiric treatment for this particular organism. So here they're not directly asking you what is the organism, but they're asking you what is the empiric treatment for this organism. So now, when modified acid fast positive showing this kind of a filamentous, right? This kind of a filamentous gram positive structure, it's going to be related to your nocardia. We all know nocardia is modified acid fast staining positive, where you use 1% of sulfuric acid, which is the modification of the acid fast staining. And now they're asking you what is the treatment or empiric treatment for nocardia. So for the empiric treatment for nocardia is actually TMP SMX, that means trimethoprim sulfamethoxazole, which is also called as the cotrimoxazole. So cotrimoxazole is actually the empiric treatment. So here I feel this year they might not ask you what is nocardia, because nocardia is asked every year. This time they actually might give you an image and ask you the treatment for nocardia. So it is going to be your cotrimoxazole, right? Moving on to the next question. So here, a diabetic patient with orbital swelling, proptosis, and black necrotic tissue, also showing broad, non-septate hyphae with obtuse angle branching. All of this is pointing towards one thing, and that is going to be your infection with some kind of a mucormycosis, right? So mucormycosis is the diagnosis, which is caused by zygomycetes. And they can ask you what is the pathogenesis of this organism. So instead of asking you directly about the zygomycetes, they might ask you that what is the pathogenesis leading to this black necrotic tissue. So mucor tends to invade the blood vessels, blocking the blood vessels, blocking the blood supply, leading to vascular thrombosis, leading to the necrosis of the tissue. So the angio invasion with the vascular thrombosis, this is going to be the answer here. Right, so angio invasion with the vascular thrombosis. So they might actually end up asking you the pathogenesis this time instead of just asking you or giving you a picture of your mucor species. Then another topic that they can ask you about is the multiple painful genital ulcers with ragged edges and purulent base, and tender inguinal lymphadenopathy showing you gram-negative cocobacilli in school of fish arrangement. Every year you get a question on some kind of a genital ulcer disease. This time, I think they're not going to ask about Neisseria, and they will ask about another one, which is very, very painful, showing you school of fish appearance, and that is going to be your Haemophilus ducreyi. So every year they ask you about other diseases caused by like herpes, and they give you urethritis with Neisseria, gonorrhea, and everything. But this time, I feel they will ask about Haemophilus ducreyi. Now, next question is hepatitis B outbreak is happening, and the autoclave temperature that they were using was 121 degrees Celsius for 10 minutes and 15 psi. And they will ask you what is the most likely reason for this sterilization failure. So sterilization failure, we all know that autoclave is done at 121 degrees Celsius for 15 minutes at 15 psi. So here the temperature is a kind of here the time is actually inadequate. Instead of doing it for 15 minutes, they were doing it for 10 minutes. So the wrong duration of exposure is the reason I feel that the hepatitis B outbreak was taking place in this case. Then another question I feel that will come, as usual, malaria comes every year. Here also malaria is going to come. So positive for malaria is there, and you will see the peripheral smear. and which species is responsible for this condition. So every year they give you a peripheral smear. This time also, I feel this kind of a picture can come where they can show you multiple rings. They can show you the headphone appearance, right? So this is the headphone appearance, some ecole forms. So all of these will be pointing towards. So ecole forms, multiple rings, right? Or the headphone appearance. Sometimes they can even give you a photo of the gametocyte. So all of these are going to point towards something which is going to be your Plasmodium falciparum. So only Plasmodium falciparum shows this. If it comes to the other options in the peripheral smear, where if they're asking you about bivax, they will show you a single ring, right? Or they can show you a schizont also. Mind you, the schizont of Plasmodium falciparum is not present in the peripheral blood because it goes and resides deeper into the vessels, into the deeper vessels. So it will not be present in the peripheral blood. So here the answer is going to be Plasmodium falciparum. The next one is going to be an HIV patient who has less than 100 CD4 count, who has low glucose, mononuclear pleocytosis. Latex agglutination is positive for the capsular antigen. And they have given you diagnosis of cryptococcus, and they will ask you what is the staining technique. So every year they give you a photo of that staining technique. This time I think they might ask you what is that staining technique. And we all know that we do the negative staining for detecting the capsule, and the stain that we use is either going to be India ink or another stain that is going to be your nigrosin stain. So this tends to stain the background and not the capsule, and hence the capsule of the India ink can become visible. So it is going to be your negative staining. Moving on to the next question. We have a 17-year-old with step ladder fever with chills, splenomegaly for past 2 weeks, and the culture is showing you a sulfuric acid producing motile with VI antigen bacteria. And they're asking you now what is the test that they can do in the 3rd week of illness. Every year we get a question on this, and the diagnosis here we all know it is going to be your enteric fever, right? It is going to be your enteric fever, and we have the very famous mnemonic called as the BASU, where in the first week we have the blood culture, right? In the first week, then the agglutination reactions, meaning the Vidal test in the 2nd week, and then we have the stool in the 3rd week, and then we have the urine culture in the 4th week. Mind you, stool and urine culture are mainly done to see the carriers, right? They're mainly done to see the carriers. That means have these patients converted into a carrier state. And if you see in the question, they are very specifically giving you a hint of a VI antigen. We all know that VI antigen persists. If it is persisting, that means the person is going into a carrier state. So in the 3rd week of illness, if we want to detect this, we will be using a test called as the stool culture. Just remember this mnemonic BASU, please. And we get a question on enteric fever every year. We might get it this year as well. Moving on to the next one, it is going to be a patient with chronic verrucous plaques, and histopathology is given to you, and they're asking you which fungi is most likely responsible. So if you see the picture here, so this is kind of some kind of a fungus which is showing a pigment formation, right? It is giving you some kind of a pigment, and it is giving you an appearance called as the copper penny appearance. Copper penny appearance with verrucous, right? With verrucous ulcers or verrucous plaques on the foot, copper penny appearance. They are also called as the medlar bodies, or they are called as the muriform cells. So all of these things are seen on the histopathology. And every time in the question, you have the diagnosis of chromoblastomycosis. Now, this time they might not give you directly chromoblastomycosis, but they actually, because chromoblastomycosis is the name of the disease, it is not the organism. What is the organism causing this chromoblastomycosis? There are multiple organisms that produce this blackish colored pigment, in this whole group of chromoblastomycosis. But this time they might actually give you the name of the fungus, and that is going to be a Fonsesia pedrosae. Fonsesia pedrosae is a fungus which produces this black colored pigment, and it comes under this whole big chromoblastomycosis group, right? So answer is going to be A, Fonsesia pedrosae. Then we have another one where they have the beta hemolytic anemia 1 week after starting high dose ceftriaxone, telling us that ceftriaxone is doing something to the RBCs. So now they are also telling that direct Coombs test is positive and what is the underlying immune mechanism. So they're trying to ask you some kind of a hypersensitivity reaction. Any of the 4 hypersensitivity reactions that we know, 1, 2, 3, and 4, any of the examples can come. Please have a clear, definition of what 1, 2, 3, 4 are actually doing. Here, the ceftriaxone is causing some problem or, going and attaching to an antigen on the RBCs that is fixed on the RBC, leading to hemolysis, leading to hemolytic anemia. So here the antigen is fixed, the antibody is going and acting on it. This particular type is your type 2 hypersensitivity reaction, which is also called as antibody mediated cytotoxicity, right? It is antibody mediated cytotoxicity. Looking at the others, IgE mediated is by your hypersensitivity 1. Immune complex deposition is your hypersensitivity 3, and your delayed type CD4 T cell reaction is your hypersensitivity 4. Antibody mediated cytotoxicity is your hypersensitivity 2, which is going to be your answer here, because here the antigen was fixed on some tissue, that was the RBCs, and the antibody was going and attaching. So it's going to be antibody mediated cytotoxicity. Moving on to the next one, we have parvovirus related manifestations. Yes, every time we get a slap cheek appearance of a child, but this time I don't think they're going to give you that. I think there are many other manifestations of parvovirus, so we have to detect the incorrect pair. So when we talk about the incorrect pair, let's see what are the diseases that are caused by parvovirus. Pure red cell aplasia in an immunocompetent adult. This is a question mark. If it is immunocompetent, no, it was seen in an immunocompromised patient, right? So in an immunocompromised patient, it can lead to pure red cell aplasia. Papular or purpuric glove and sock syndrome in younger adults, that is true. It can be seen. Hydrops fetalis in a pregnant woman, that means in pregnancy, if a woman is getting parvovirus, the child will have hydrops fetalis, that is true. And in children, erythema infectiosum. So this is what is called as a slap cheek, right? This is what is called as the slap cheek appearance, and that is true. It is seen only in children. So our answer here is going to be only option number 1. That means 1. That is the incorrect statement. Rest all the statements related to parvovirus are true. So this kind of brings us to the end of the all the other questions or the probable questions that can come in your exam. So all the best from my side and crack it.
Hi, students. So this will be a very rapid revision. Not revision. I will just give you the hint of the important, very, very important questions which are likely to be asked and where the students commit mistakes and which you should really focus on in forensic medicine. So, for example, there are various terminologies and medical negligence. Defenses which a doctor used against medical negligence, don't get confused into that. Injury due to unexpected side effects, that will be therapeutic misadventure, which is same as medical maloccurrence. Wrong diagnosis due to atypical symptoms, error of judgment. Patient can file civil case within 2 years, that is res indicata. Okay, once the case decided, it cannot be filed as a fresh case, that is res judicata. Patient himself volunteers, voluntary non-fit injuria. Both negligent, contributory negligent. Okay. Similarly, now there are common medical legal doctrines. The problem is students confuse between these terms. So that is very important as a last minute revision. Don't get confused. Doctor should not reveal patient secrets. That is professional secrecy. Exceptions to this rule is privileged communication. Okay. Then usually doctor should inform everything about disease. That is doctrine of full disclosure. But then there is an exception which is called therapeutic privilege. Then patient can refuse treatment, that is doctrine of informed refusal. Hospital at fault, corporate negligence. Manufacturer at fault, products liability. Responsibility for the act of another, vicarious liability. Fact speak for itself, res ipsa loquitur. So main thing is these terminologies, you should not get confused. Now, you don't have to remember the old laws. Just remember IPC is changed to BNS. CRPC is changed to BNSS and IEA is changed to BSA. Okay. Now, the important BNS I will tell, very important is act of unsound mind. That is 22 BNS, In emergency, consent is not required. That is 30 BNS. And deaths due to any rash or negligent act, that is again very, very important. That will be 106 BNS. Then for hurt, it will be 114 BNS. And for grievous hurt, it is 116 BNS. Now, two inquest sections are very important. For police inquest, the section is 194 BNSS, and magistrate inquest section is 196 BNSS. Okay. Then please remember, on stains, the questions are commonly asked. First thing is to whether it belongs to human beings or not. For that, we do precipitin test. This is for species, but then whether we have tests whether it is semen or not, whether it is blood or not. For both, we have presumptive and confirmatory. Presumptive test for semen is it shows fluorescence under ultraviolet light by Wood's lamp. And then there are two microchemical tests for seminal stains, Barbario and Florence. Remember the mnemonic, semen of BF. Confirmatory test, sperm detection, acid phosphatase, protestate specific antigen, creatine phosphokinase. Please remember, CPK is a component of sperm, so it is useless in a sperm mix. Then for blood stains, similarly, we have presumptive test, macrochemical test, which use hydrogen peroxide, for which you remember the mnemonic is hydrogen peroxide ka blog. Okay, so Castle-Mayer, benzidine, leucomalarkite, orthotoluidine, and guaiacum test. Luminol spray test is used for invisible stains. Then confirmatory test is blood cell spectroscopy is the best test. And then in microchemical, we have Tickman and Takayama. Okay. Please remember, very commonly the question will be asked, and they will give you old or dry stain. There you always mark confirmatory test as the answer, but then there are two exceptions which are confirmatory but not good in old or dry, which are acid phosphatase and Tickman. Acid phosphatase and Tickman. Okay. Now, autopsy technique, remember LGVR. So first, all together, large, Lutele, then Gons, each block separately, Virtuos one by one, Rokitansky, in situ. In situ is for infection, example HIV, etc. Letulo is for infants, for congenital anomalies. Okay. Then adipose mummification, which one is orderless? Mummification is orderless. And remember the kind of temperature required. Adipose requires warm and moist. And mummification requires hot and dry. Okay. Then various indices will be asked. If any index is asked, for example, cephalic index is used to calculate. Don't mark stature or age as the answer. Answer will be either race or sex. If the index pertains to skull or limbs, then the answer will be race. If it pertains to sternum or pelvis, then the answer will be sex. So cephalic index, remember the mnemonic DMB 70, 75, 80. So dolichocephalic 70 to 75, mesenterocephalic 75 to 80, brachycephalic 80 to 85, and dolicho is found in ANA, Aryans, Negroes, Aborigines. Okay. Then sex from male, please remember all male bones are larger, rougher, heavier, more prominent, and they are squarish. Females are rounded. Females are rounded. And please remember that pelvis is the best bone. It gives 95% accuracy. Pelvis 95. Then please remember, when it comes to the skull, then these are the three exceptions, which are frontal eminence, parietal eminence, and orbits, which are large and prominent in females. Then please remember, in pelvis, because the pelvis has to be wider for childbirth, so most features are wider, larger, and more prominent in females. Okay. But acetabulum and opteroforamen will be opposite. They will follow the general rule. They will be large and in males and small in females. Then fingerprints, remember the mnemonic love, wife, and children. Okay, so loop common based on visibility, it will be patent print, plastic print, and latent print. Okay, and latent print. Then mechanical asphyxia, anything other than drowning and compression of neck. Please remember that will be suffocation. So don't get confused. What all is suffocation? Anything other than compression of neck and drowning is suffocation, asphyxia. Dribbling of saliva occurs opposite to ligature knot. And whereas in La facie sympathetic, eye open and pupil dilate on same side of ligature knot. Remember this, okay? Then neck injuries, and if any neck injury is given in the exam, answer will be, most common answer will be manual strangulation followed by ligature strangulation followed by hanging. But there's an exception. If it is hyoid fracture or carotid artery, then it will be again manual strangulation but followed by hanging and then followed by ligature strangulation. Cervical vertebrae only in judicial hanging. Then type of drowning, one is typical, atypical. Atypical is of 4 types. Dry drowning, where death occurs due to laryngospasm. Post-immersion, death occurs later. Hydrocution, sudden death occurs. And shallow water is in bathtub. And then please remember, there are 8 signs of antemortem drowning. These are all the signs of antemortem drowning. Signs of immersion are those which can be seen in both antemortem and postmortem. These are cutis and serina and washer woman hand. Then grievous hurt, please remember one thing, that even partial loss is a grievous hurt. Abrasion is not a grievous hurt, but lacerated wound is a grievous hurt. Even minor fracture is a grievous hurt. And now the duration has changed from 20 days to 15 days. Then please remember multiple parallel wounds. These are hesitation marks, or they indicate suicide, whereas these are defense wounds, and defense wounds indicates murder. Okay. And then skull, the different kind of skull fractures. This is linear fracture, and this is depressed fracture or signature fracture. So skull fractures are very important. Go through all the skull fractures. Then bomb blast is again very important. Primary blast, air blast, most common is tympanic membrane, followed by lungs, followed by GIT. Underwater blast, GIT most common. Then secondary blast injury is Marshall's triad. Third is victim thrown away due to velocity wind, tertiary blast injury. All other are quaternary. Crude bomb thrown by hand is Molotov cocktail. Okay. Then distance is based upon contact, close contact, intermediate, distant. In contact entry, singeing, blackening, tattooing present, but just on the margins. Close contact, singeing, blackening, tattooing present around the wound. Intermediate, only tattooing. Distant, nothing or none of these sorts present. Then heat cramps is followed by heat syncope. Heat syncope is followed by heat exhaustion. Heat exhaustion is followed by heat stroke. Heat stroke, here the body temperature, please remember, is more than 40 degrees Celsius or more than 104 degrees Fahrenheit, and sweating is absent. Then burn surface area, very important. It is separate for adults and children that you would have studied in surgery. Then electric burns, electric contact burn is joule burn, and this is spark burn, and this is crocodile burn. Okay. Then medical legal importance, various scenarios. For example, past history. So anything related to past history is not required. Police should always be informed. In camera means only selected people allowed. If the evidence is wet, then you should air dry it under a shade. Okay. Then sexual perversions, very important, like sadism, infliction of pain. Opposite of sadism is masochism. Then watching people, voyeurism. Rubbing genital is voyeurism. Then exposure is exhibitionism. And then fetishism we have. And then this is transvestism. And then we have eating of dead body, necrophagia, sex with dead body, necrophilia, sexual desire, satyriasis, sexual desire in females, nymphomania. Okay, MTP Act, again, very, very important. Go through it. Then age of fetus can be determined by the Hesse's rule. Please remember Hesse's rule for the age, and here the length is crown heel length. Then please remember, people get confused between superfecundation and superfetation. Superfetation, there are 2 T, so it is in 2 menstrual cycles. So 2 menstrual cycles, so different development. And then please remember, 22 BNS is for criminal responsibility of mentally ill, but there are other rules also. You should be definitely knowing their names, very important. Irresistible impulse, Durham's currents, American law, doctrine of partial responsibility. What Durham's rule, remember the phrase, product of mental disease or defect. Currents rule, remember the phrase, capacity to conform to requirements of law. Then color of PMS, very important. Then this is CO cyanide, cold cherry red. Cherry red is same as bright red, bright pink. Phosphorus or copper, dark brown or yellow. Dark brown or yellow. Then chocolate brown will be in methemoglobinemia. Hydrogen sulfide is greenish. Okay, then garlic smell is seen in TOPA. Garlic smell is seen in TOPA. Fishy odor is seen in phosphide. These two are very important. Then contraindications of gastric lavage, all corrosive, convulsions, comatose. Please remember, except carbolic acid. In carbolic acid, though it's a corrosive, we can do the gastric lavage. Activated charcoal is contraindicated in mohawk. Remember that, very important. Then removal of alkaline diuresis is required for very few poisons: BCMS, barbiturates, chlorpropamide, methotrexate, salicylates. Hemodialysis is useful in heavy blast. Again, very, very important. Then antidotes, all you have to remember: methyl alcohol, ethylene glycol. We know it is ethyl alcohol or fomepizole. Then benzodiazepine, flumazenil, opioid, naloxone, sympathomimetic, diazepam, anticholinergics, cholinergic drug like physostigmine, cholinergic drug, atropine, organophosphates, atropine, pyridoxine, diazepam, carbamates, atropine and diazepam, no pyridoxine, organochlorine, it will be only diazepam, and cholestyramine. HOE causes hypocalcemia, so here you will use ethylene glyco. Sorry, HOE causes hypocalcemia, so that here you will use calcium gluconate. Antidote list is very, very important. Heavy metals, chelating agents, titanium, it is potassium ferric ferrocyanide. Copper is penicillamine and potassium ferrocyanide. Phosphorus 4, so CuSO4 and KMNO4. Then snake, anti-snake venom, scorpion, prazosin, carbon monoxide, 100% oxygen. Phosphide is MgSO4. Methemoglobinemia is methylene blue. Then cyanides, we have various amyl nitrite, sodium nitrite. Then we have this amyl nitrite, sodium nitrite. Then we have hydroxycobalamin, which is the best. Please remember, hydroxycobalamin is the best. Then acetaminophen, N-acetylcysteine, vitamin K1 for oral anticoagulant, digoxin, digitalis purpura, oleander. Same features. It will be, you will give digibind. And drug causing acidosis, you will give sodium bicarb. Okay. Then please remember, very commonly the question is all depressed, CNS depressants, all depressed, agitated, sympathomimetic, dry is anticholinergic, and leaking is cholinergic. Please remember the examples. Abbo is CNS depressant, Setplax, sympathomimetic, cocaine is a part of sympathomimetic. All antis are anticholinergic. Then atropine, dhatura, these are all anticholinergic. D-monk is cholinergic, with organophosphate very important amongst them. Ethyl alcohol, again very important part of psychiatry. Okay, then these we have. Then after that, in insecticides, all whenever force on is there, organophosphates. Carbs are mine is carbamate. Then Ne or In, organochlorine. Thrins is thyroid. Thrin means thyroids. In arsenic poisoning, please remember peripheral neuropathy, skin, nail changes. These are most. Then in heavy metals, 4 are very important: arsenic, thallium. Thallium and arsenic are similar, but thallium you will choose if there is alopecia. Okay. For mercury, tremor is the most important feature. Then acrodynia is chronic mercury poisoning in children, and minimata is by the organic mercury. Then in lead poisoning, there will be anemia, basophilic stippling, as you can see, then colic, constipation, foot drop, encephalopathy. Okay. And then copper, it's blue in color. So main organ factors are brain, liver, and eye. There you can see KF ring. KF ring you will see. And then in snakes, the neurotoxic, cobra, crate. Vasculotoxic will be all vipers. Myotoxic will be snake. Okay. Then toxalbumin, albumin, crotin, resin, artificial bruise, semicarpus anacardium, calotropis, and plumbago. Inhibit protein synthesis, abrin and resin, make suis, abrin, this is also abrin to move part on clothes, semicarpus anacardium. Strychnine, please remember all S for strychnine. Strychnine is post-synaptic, tetanus is presynaptic. Strychnine inhibits glycine, and tetanus inhibits both glycine and GABA. Cardiac poison, please remember Dhonak are the cardiac poisons. So these were the most important topics. Do revise them. Don't get confused. Thank you so much. All the best.
So here we are discussing about the most important topics in view of INI-CET exam. So just quickly going through, you have the auditory pathway. So the sound enters into the external auditory canal and it strikes the tympanic membrane, vibrations of the tympanic membrane through the ossicular chain, through the oval window, foot plate, and into the sound will enter into the cochlea, scala vestibuli part. The basilar membrane will vibrate and the organ of Corti will vibrate. Outer hair cells will vibrate. So the hair cells will bend against the tectorial membrane that opens up the potassium channels. So nerve action potential gets generated and this is carried through the eighth nerve, right? From the eighth nerve, the cochlea where it starts, all the spiral cell bodies join to form a spiral ganglion. And from there, through the auditory nerve, they are transferred to the cochlear nucleus, olivary complex superior, lateral lemniscus, and inferior colliculus, medial geniculate body, auditory cortex. So it goes on. E. colima is the code you need to, mnemonic you need to remember for auditory pathway from the eighth nerve. And coming to the audiometries, as I have already told you, if you are getting two waves closer to each other within the normal range, up to 25 decibels loss can be taken as normal. This is normal. If you are getting bone conduction abnormal, normal and air conduction abnormal, that means there is a airborne gap, that is conductive hearing loss. Both waves together in the abnormal range, that is SNHL, and conductive plus SNHL mixed. Both are in the abnormal range and separated by a gap. This is mixed hearing loss. Coming to the Carhart's knots in otosclerosis, on bone conduction wave at 2 kHz, you will get this. This is at 4 kHz dip, where you will see this noise induced hearing loss. And in Meniere's disease, you will see upsloping, and in presbycusis, you will see downsloping audiometries. And coming to this otoacoustic emissions, so this detects the outer hair cell function, and if it is normal, your ear is functioning normal. And this is BERA. Usually, these two are the hearing screening tests done. Most commonly done is otoacoustic emissions, and first test is otoacoustic emissions. If it is a ICU admitted patient on ventilator support for more than 5 days, or you are suspecting hyperbilirubinemia, then BERA becomes the first investigation of choice. So this BERA, you need to remember there are multiple waves. Each wave corresponds to your auditory pathway nuclei, and E. coli, wave 1, wave 2, wave 3, wave 4, wave 5, wave 6, like that it will be coinciding. And wave 5 is the most prominent in BERA. This you need to remember. The cochlear implant parts are also very important. So you will have an external unit implanted outside. So that will be having a microphone that receives the sounds, a digital processor that converts the sound into electricity, and through the transmitter inside, receiver stimulator package is there. From the transmitter, the electrical energy gets transferred to the receiver transmitter inside, and through the receiver transmitter and through the electrode into the cochlea it will go. So in cochlear implantation, auditory nerve should be intact. If auditory nerve is not functioning, you go for auditory brainstem implant. Directly the ABSI is implanted on the brainstem, on the lateral recess of your fourth ventricle it is inserted. And this is regarding various hypoactive and hyperactive labyrinthine lesions. So just remember one thing, serous labyrinthitis and early Meniere's are hyperactive. If you can remember these two, all the other are hypoactive. Most of the majority of the lesions are hypoactive. So in hypoactive lesions, the nystagmus will be towards the opposite side. Okay. So if it is left side hypoactive lesion, left-sided hypoactive lesion, the nystagmus will be towards the opposite side. Okay, the direction of the nystagmus is always declared by the fast component side. Okay, but so if it is right beating nystagmus, if the fast component is towards the right side, then it is right beating nystagmus, but the lesion will be on the left side. Okay, so for a left hypoactive labyrinth, a right-sided fast beating will be there, left-sided slow beating will be there, right-sided nystagmus will be there. So if the nystagmus is beating slow towards the left side, left hypoactive, beating fast towards the right side, left hypoactive. Okay, it can be either left hypoactive or it can be either right hyperactive. It should be the diagnosis. Okay, this should be the differentiation. Now coming to the narrow supply of the larynx, vocal cords are supplied by your various, the larynx is supplied by various intrinsic muscles of the larynx are supplied by both your SLN and RLN. Left RLN is more longer than right RLN, so it will be having more chances of getting paralyzed. And all the muscles are supplied by recurrent laryngeal except cricothyroid, which is supplied by external branch of SLN. And sensory supply above the level of vocal cords is by internal branch of SLN. Below the level of vocal cords is by RLN, that you know. So coming to vocal cord palsies, unilateral vocal cord palsies, vocal cord is in where intermediate cadaveric position, breathy voice is there, no respiratory difficulty, medialization is the treatment of choice, and after 6 months. And coming to the bilateral vocal cord palsy, bilateral RLN, both vocal cords are paralyzed and lying in paramedian position. So breathing difficulty, emergency tracheostomy. After 6 months, go for permanent lateralization. Type 2 ischemic thyroplasties, right? Coming to juvenile nasopharyngeal angiofibroma, you have Hallman-Miller sign, adolescent male, recurrent epistaxis, no stimulatory episodes, no inflicting episodes are there, no stimulus is there, spontaneous nasal bleeds, Hallman-Miller sign, anterior bowing of the posterior maxillary wall, Weber-Ferguson incision is given, and the maxilla is entered through the Weber-Ferguson incision, and you can enter from the back wall of the maxilla, you can enter into the pterygopalatine fossa, and you can remove the entire tumor from there. And from the nasal cavity, you can remove directly through the nasal cavity, right? So this is about your JNA. So these are the few topics. Coming to the nose also, kindly go through the epistaxis part once. So hopefully, so all the best for your exam. Hopefully these are the most frequently asked questions in your INI-CET. So once again, I wish you all the best for your exam.
Hello dear students, as we are very close to our final INI-CET exam, let us take a last sprint through ophthalmology and let us hope that some very important topics are covered in this and we get some questions out of these topics that I think are the hot ones in the upcoming INI-CET exam of 2026. So one important thing that is there is regarding the refractive surgeries. They've been asking questions about refractive surgery because it is a very hot topic amongst all medicos. So refractive surgery eligibility criteria, we know the age has to be more than 18 years, stable refraction for at least 1 year duration. The higher criteria are keratometry values, that is the curvature values have to be between 39 to 47 diopters. Now there can be a question where they can say what will be the keratometry value after the refractive surgery. So after the refractive surgery, it should not go less than 34 diopters. So that is one thing that can be asked in INI-CET exam. Initial corneal thickness should be at least more than 480 microns. And the residual corneal thickness, residual corneal stromal bed should be more than 300 microns. That is also there once we are planning for any refractive surgery. US FDA limits the cornea-based surgeries for myopia up to 12 diopters, astigmatism 6 diopters and hyperopia of 6 diopters. That is the US FDA limit for any cornea-based refractive surgeries. Coming to other surgeries, there can be lens-based surgeries also. In cornea-based surgeries, we know that there is an incision-based surgery. RK is an incision-based surgery. PRK and LASIK surgery, they use excimer laser. Okay, they use excimer laser. Smile and silk, these are the surgeries which use the femtosecond laser. Okay, that is ND glass laser, 1053 nanometers, that is there in smile and silk surgery. These do not use the excimer laser, they use purely femtosecond laser. The other surgeries can be lens-based surgeries where there is a phakic IOL, that is also called as ICL. For implanting a ICL, you require at least a 2.8 mm anterior chamber depth. It is implanted over the natural crystalline lens. You can combine, in case of a very high power, you can combine the two. You can put an ICL as well as you can do a LASIK surgery on the cornea. So combination of both is called as bioptics. One thing that can be asked is, very hot topic is flapless surgery. Okay, so see here, in case of the smile and silk surgery, it is a flapless surgery. Okay, the LASIK and femtosecond LASIK, these are flap-based surgeries. Another flapless surgery which was initially picked up was the surface ablation, that is the PRK, photorefractive keratectomy. Smile and silk, these are flapless surgery. You do not create a flap. You go inside the corneal stroma, you pull out a lenticule. That is there in smile and silk surgery. And please remember one more very important topic is that smile and silk is not used for hyperopic LASIK. Hyperopic correction cannot be done with smile and silk surgery as of now till date. For patients with hyperopia, only the LASIK or PRK can be there. Okay, so you cannot do smile and silk surgery in case of hyperopia. That can be a twist that can be added to the question. On the next topic, that is refractive control options. These are very new. So various refractive control options are use of low dose atropine at night time, use of myopia control glasses. These are very commonly being used nowadays, and orthokeratology, not very popular yet in India, but yes, it is something which is being done abroad. So ortho lenses are hard lenses which are used at night time. They flatten the cornea, okay, and they prevent the elongation of the eyeball. These are the three refractive control options, basically meaning myopia control options. Okay, again, they are for myopia control. They are not for astigmatism. They are not for hyperopia. They are for myopia control options because myopia is increasing because of the more near work, more gadget use. Next topic is the named cataracts. We all have done this. Sunflower cataract, Wilson disease, snowflake cataract, diabetes, that is sorbitol accumulation, oil dropper cataract, galactosemia, galactoil, so that is a reversible cataract, galactokinase deficiency and GP-UT deficiency. These are galactosemia, and complicated cataract as a complication of the intraocular diseases, TIGER, tiger, and BAPP are the mnemonics for the complicated cataract. I hope you remember these. Now, in cataract surgery, it is very important that there are newer developments that are happening. So, one is what laser is being used in cataract surgery nowadays. So, again, the femtosecond laser, ND glass laser, that is being used in femtosecond laser assisted cataract surgery. So, it is assisting the cataract surgery. Nucleus is still being removed by the phaco tip only. So please remember this much, okay, that ND class laser, they will assist in the cataract surgery, but for removal of the nucleus, you are still using the phacoemulsification that is there, okay. Now, once you have done the cataract surgery, then you need to implant the intraocular lenses. Various lenses are there. This is a monofocal lens, this is a toric lens, this is a multifocal lens, and this is an accommodative lens that is there. The newer lens that is there is EDOF lens, extended depth of focus, extended depth of focus, and now slowly the technology is moving towards the full range of vision correction. Okay, now these are again monofocal lenses, but they do not have rings like these. So ringless lenses are coming up, which can provide full range of vision that is there. Okay, otherwise with monofocal lenses, with toric lenses, you will get a good distance correction, but you will require a reading correction. Okay, distance correction will be good, but reading glasses will be required with these. Okay, with these, reading glasses are not required. These are not very popular. These are not very successful because the fibrosis happens and they are not very successful. Depth of focus lenses, they provide a good distance and intermediate vision. Okay, they provide a good intermediate vision. Intermediate is as in seeing a laptop or as in seeing a dashboard of a car. So they provide a good intermediate vision, but reading glasses are still required with EDOF lenses also. Next is nowadays complication of cataract surgery. Okay, so most common complication we know is the PCO formation, which can come as an image-based question. It has come as an image question. Most dangerous complication we know is the infection. Okay, that is endophthalmitis. They have recently asked what is the causative organism. It is the Staph aureus. If they move on to the treatment, what is the treatment? Treatment is going to be intravitreal antibiotics. Wherever there is infection, you have to give an antibiotic. So intravitreal antibiotics is the treatment for endophthalmitis, and you should be knowing that you have to differentiate it from the TAS, toxic anterior shock syndrome. TAS is something which is an allergic response. It's an allergic response, and it commonly presents sooner. It presents within next 24 to 48 hours of surgery, whereas endophthalmitis infection usually presents between 3 to 7 days. Okay, so that is there. What is the most important step in prevention of endophthalmitis? It is the use of povidone iodine. Povidone iodine. Okay, in the conjunctival sac, just pre-operative to the surgery, that is the most important preventive step. We have done this. Okay. Now, other complications which have been now asked are the subluxation of the intraocular lens. Okay, even after surgery, the IOL can also subluxate. We have always learned about subluxation of the natural lens, crystal lens, Marfan syndrome, homocystinuria, but many times after surgery, the lens that we have put, the PCIOL, that can also subluxate. So this is what is called as sunrise syndrome. This is sunset syndrome. Sunrise, it has gone up. Sunset, it has gone down. We can get an opacification of the IOL material itself. Okay, please differentiate this from the opacification of the PCO. Posterior capsular opacification is the opacification of the capsule. The lens is clear. Here, the opacification of the intraocular lens has happened. This is with the material. Sometimes the material gets opacified by itself. Here, the treatment is going to be, you will have to explant this IOL and you will have to put a new IOL. Okay, that is there. So, PCO can be shown like this. This is an oblique illumination. On the slit lamp, you are seeing this oblique illumination, and this is a retro illumination. Retro illumination. These are both PCO. Secondary cataract, after cataract, these are the names. Patient will not have pain in the PCO. Patient normally presents with paleness, decrease of vision after successful cataract surgery, usually presenting at least 1 year or beyond. Okay, so that is how the PCO patient presents, and the treatment is ND-YAG capsulotomy. You have to create a capsulotomy. Okay, but here in opacification of IOL, you have to expand the IOL. Next, moving on to glaucomas. Various named glaucomas, secondary glaucomas. Primary glaucoma we know are open angle closure. These are the various secondary glaucomas. Pseudoexfoliation syndrome, where you had a target sign. Neovascular glaucoma, Davies sign, rubeosis iridis. Okay, rubeosis iridis. It is because of production of the VEGF, and the definite treatment is going to be PRP. You have to kill the retina, anoxic retina. Okay, ischemic retina is converted into anoxic retina. Correct. Pigment dispersion glaucoma. Where is dispersion of the pigment? From the iris. So obviously iris will have a trans illumination defect, and deposition of this pigment on the endothelium will lead to a Krukenberg spindle sign, which is looking like this. Okay, and sampulosis line is seen here also. Sampulosis sign is seen in pseudoexfoliation also, in both of them. Malignant glaucoma is seen after intraocular surgery, where there is aqueous hysterexis syndrome. And the only glaucoma where atropine is the drug of choice is indicated is this one. Move on to next. Various lasers that is being used in glaucoma are argon diode laser trabeculoplasty. Trabeculoplasty is for open angle glaucoma. The angle has to be open, only then you can reach the trabecular meshwork and you can do a trabeculoplasty. Okay. For angle closure glaucoma, we do a iridotomy. We create a hole inside the iris. So iridotomy is done by the ND-YAG laser. What is the wavelength? That is the 1064 nanometers. This is ND-YAG. Femtosecond was ND glass laser. So remember the lasers. Lasers can also be asked in the questions. Cornea, you can have keratoplasty and keratoconus. These are the two important topics. What is type of refractive error? Irregular myopic astigmatism. Keratometry is increased. Pachymetry is decreased. Investigation of choice is topography. Okay. Vaux try, Munson sign, Rizzuti sign, Fleischer ring is iron deposition ring. And on retinoscopy, you see a scissor or a yawning reflex. On distant diadothalamuscopy, you see a oil droplet reflex. Here it is oil droplet reflex. Galactosemia was oil droplet cataract. Okay. Keratoconus treatment has been asked. So very important are RGP lenses, hard contact lenses. C3R, corneal cross-linking, where you put riboflavin and you do a UV radiation. Intax is implantation of the semicircular rings in the corneal stroma to flatten the cornea. You can do a corneal transplant. It can be a full thickness transplant or it can be a partial thickness transplant. Partial thickness is one which is called as DALK, deep anterior laminar keratoplasty. Keratoplasty is very, very important. Last year there was a question in which they had given you a patient of keratoconus and they had asked you what is the treatment that has been done. There was an air bubble which is being shown. This is basically a stage of acute hydrops. Because of the stitching, there happens to get water collection inside the corneal stroma. Okay, this is acute hydrops. Because of the rupture inside the descemet membrane, there is ingress of the aqueous into the corneal stroma, and that is what is called as acute hydrops. So you have to put an air bubble here. You have to put an air bubble here so as to tamponade this and to push the water out. So this is what is there. Which air bubble is used? It is C3F8. And post this, the patient lands up in this kind of corneal scar. That is the treatment for acute hydrops. That is that. Okay. Ultimately, you will have to do a corneal transplant. You will have to replace this entire cornea by doing a corneal transplant. Corneal transplant, again, as I was telling you, can be a full thickness transplant or a partial thickness. But here, because it's a corneal scar, so you will have to do a full thickness transplant. Now, corneal transplant is very, very important. Eye donation is a cadaveric donation. It is to be done within 6 hours of death. Complication, most common complication because of suture is astigmatism. Okay, but you can get a rejection also, that is Khodados line and Krashmer spots. Okay, various storage media, very simple, is the bottle that is there, that is the moist chamber. You can have a MK media, that is for 48 hours. You can have U-Sol media, K-Sol media, Optisol media, various media that are there for the storage of the cornea. DALK is where you do anterior graft. Endothelial grafts are DSEC and DMEC. Okay. In case of corneoplasties, where the corneal transplant has been rejected, okay, then you can go for a keratoprosthesis. Okay, in case of a patient who is bilaterally blind, to restore some vision, we can do a keratoprosthesis. It is basically osteo-odonto-keratoprosthesis. Osteo is bone, odonto is teeth. And you have a cylinder, the optical central center. So you suture this with the sclera. This is osteo-odonto-keratoprosthesis by using the bone and the dentate. Okay, these are for failed corneal transplants. In conjunctiva, we know that there is flectin, there is spingicula, pterygium, and bite spot. These are the various topics that can be asked in conjunctiva. Flectin is type 4 hypersensitivity. VKC is type 1 hypersensitivity. Remember, VKC. For flectin, for 4. Type 4 hypersensitivity is flectin against TB and staphylococcal antigens. Spingicula and pterygium both are elastotic degeneration. Pterygium surgery is perfect surgery where you have to replace the conjunctiva and the limbal stem cells have to be replaced by a conjunctival autologous transplant. Bite spot is where in vitamin A deficiency and it is X1B classification, and vitamin A supplementation doses you should be knowing. In neurophthal, the visual field defects are very, very important. They can be asked and they are very, very sitting questions, very standard questions. In case of a chiasmal lesion, look at the heteronymous field defect, that is opposite sides. Always remember, only chiasmal lesions cause heteronymous field defects. One eye has a left heart field defect, the other eye has a right half field defect, that is the chiasmal lesion. Only chiasmal lesion will have heteronymous. Rest all the lesions are homonymous, and rest all the lesions are going to be contralateral lesions. So the defect is on the right side, the field defect will be on the left side. Okay? If the pathology is on the right, the field defect will be on the left side. It's always contralateral. Okay? Pie in the sky, pie on the floor, central sparing, occipital lesions. These are the various visual field defects that can be asked. In the other important topic in neurophthal is the differentiation between papilledema and optic neuritis, that is papillitis. Remember the 5 signs of optic nerve disease: vision, color vision, visual field defects, the pupil reaction, and the fundus examination. So just remember, the vision is going to be very reduced in optic neuritis. It will be normal in papilledema. Color vision is going to be affected here. It will be normal in papilledema. Okay. Pupil reaction. will be RAPD, will be normal here. Okay. In case of the visual field defects, there is central scotoma or a centrocecal scotoma, whereas enlargement of the physiological blind spot in papilledema. And on fundus examination, on fundoscopy, you will have papilledema is more edema. Okay, papillitis is inflammation, so less edema. Okay, but there will be edema, and the vision is going to be severely reduced in ophthalmitis, where it is normal in papilledema. So these are the differentiating points. Most common cause of ophthalmitis is multiple sclerosis, demyelinating disorder, and the treatment is ONTT, optic neuritis treatment trial, very high dose intravenous steroids followed by oral steroids. Direct oral steroids are contraindicated. This is the important point. In case of squint, for assessment of squint, various investigations are there. They have asked questions on these, so that should be on your tips. First and foremost, in any squint is going to be checking the visual acuity and the refractive status of the patient under the use of cycloplegia. That is the first assessment. Then you can do a corneal reflexes, that is the Hirschberg test. They have asked about how much degree it is, 15 degree, 30 degree, 45 degree squint. That is degrees. Degrees ka double is the prism diopter. 15 degrees 30 prism diopter, 30 degrees 60, and 45 degrees squint is 90 prism diopters. That has been asked. Cover uncover test. Okay, you do a cover test, you do an uncover test. I will be talking about that very shortly. Maddox rod looks like this. Maddox wing looks like this. Hess chart Lee screen is used for paralytic squint assessment. Okay, and Worth-Ford test is basically for assessing the right eye suppression, left eye suppression, where the patient is using the red green glasses. That is the Worth-Ford test. We have done this in our classes. In case of cover test, basically cover test is done for patients with your manifest squint. Okay, where you cover the normal looking eye and the manifest squint, the squint which is deviated, look at the behavior of that eye. That is the cover test. Cover uncover test is done for both phoreas and tropias. Okay, that is the cover uncover test. In case of treatment of squint, first is always eyeglasses or contacts. You do an eye patch for amblyopia treatment, and then you use prisms, and surgery is always for the last. So remember the sequence of treatment that can be asked. In case of amblyopia, do not mark the video games. Okay, video therapy, computer-based vision therapy, that is the correct option. Okay, otherwise amblyopia, in case of strabismic amblyopia, you would do a squint surgery. That is definitely for strabismic amblyopia. Moving on to the retina. In ARMD, age retinal macular degeneration, that is a very important topic, because as the longevity is increasing, more and more cases of ARMD are being seen. Okay, it is becoming more prevalent with the use of more fast foods, less use of antioxidants. So ARMD is basically collection of the metabolic byproducts under the retinal pigment epithelium, and finally there is break in the Brooks membrane and the new vessels grow from the Brooks membrane. So ARMD can be of two types, the dry atrophic non-exudative type or the exudative wet type, that is the wet ARMD. Wet ARMD results in more vision loss but is the less common type. The more common type is the dry ARMD, which is presented by drusen, that is the collection of the metabolic products into the underneath the retina. Okay, so the treatment for dry AMD is going to be more use of antioxidants, lutein, zeaxanthin, astaxanthin. That is the treatment for dry AMD. Wet AMD is treated by use of anti-VEGF injections. Anti-VEGF injections we have done: bevacizumab, ranibizumab, brolucizumab, aflibercept, and the latest one is the faricimab. These are given intravitreal injections. Remember, the use of VEGF, anti-VEGF injections is also there in patients with diabetic retinopathy and in patients with ROP, retinopathy of prematurity. So anti-VEGF injections are these places where they are being used. Orbit, in orbit we have to remember the orbital infections. It can be preceptor cellulitis or orbital cellulitis. In case of orbital cellulitis, where the infection has gone into the orbit, there the movements are going to be restricted. Vision problems might be there. Proptosis is there. The forward movement of eyeball, that is there. For measurement of proptosis, what is the instrument that is used? It is the Hertel's exophthalmometer. Okay, so that is there for proptosis and orbital infections. In case not treated timely, it can result in what? Cavernous sinus thrombosis. What is the first muscle to be involved in cavernous sinus thrombosis? It is the other eye, lateral rectus, the sixth nerve fancy. Okay. Orbital tumors, intraocular tumors are various causes of leukocoria. Out of all the causes of leukocoria, only and only retinoblastoma has intraocular calcification. And please remember the age group. Age group of retinoblastoma is going to be less than 5 years. Retinoblastoma is a life-threatening tumor. It needs to be treated as soon as possible, or we have to do a enucleation. It is enucleation. It is not evisceration. Okay, for tumors it is enucleation, where you have to remove the entire eyeball. Okay. Congenital cataracts, coloboma, Coats disease, PHPV, ROP. ROP is retinopathy of prematurity for children presenting getting birth before 34 weeks of gestation, especially if exposed to increased oxygen concentration. Between 34 to 36 weeks, if there are other risk factors such as septicemia, your lung infections or blood transfusions, so those are also at risk of. When is the first examination done in ROP? It is at 4 weeks from the postnatal age. In case of lid infections, this is hordeolum externum, hordeolum internum. Externum is also called as sty. It is the infection of the Zeiss gland. Internum is basically the infection of the meibomian gland. Okay, meibomian gland is present in the tarsal plate. These are the meibomian gland openings are there. Okay, what is the painless swelling away from the lid margin? It is again infection of the meibomian gland, but it is a lipogranulomatous inflammation, and this is what is called as chalazion. Treatment of chalazion is incision curettage. You have to give a vertical incision. Please remember this. And chalazion clamp has come as an instrument that has been asked. These are the various topics on ocular. Blunt trauma. Trauma is very, very important because trauma is something which everybody comes across in your neighborhoods, and as doctors we expect everybody to know about trauma. Okay. Rosette cataract, rose-shaped cataract, that is the traumatic cataract. Voschius ring is deposition of the pupil ring, iris pigmentation deposition on the anterior lens surface, that is the Voschius ring. Hyphema has been asked. If it is a total hyphema, then it is 8-ball hyphema, that is the complete. Disinsertion of the iris from the root will result in iridodialysis and results in a D-shaped pupil. Berlin's edema is an important cause of cherry red spot. Okay. Bee sting, Berlin's edema, sialidosis, Tay-Sachs, ischemia, Niemann-Pick, and gangliosidosis. Bee sting is CRAO, is a cherry red spot, and CRAO is an important cause that is there. Ecchymosis, blowout fracture, fracture of the floor of orbit, okay, entrapment of the inferior rectus muscle. These are all the very topics of blunt trauma. And very important is chemical injury. Okay. Chemical injury, the most important point is copious irrigation, that is chemical injury. And in case of drug of choice, they ask for chemical injury, it is going to be use of steroids. Steroids in eye drop form, steroids systemically also, so that is there. Adjuvant therapy is going to be atropine. You have to give atropine for chemical injuries also to give relax, to pain relief to the patient. So that is the treatment for chemical injury. Please remember this. So these are some of the topics that are there, and I hope some of them come in the exam and you all are able to succeed. Just like every teacher, I would like to say, please remain calm during the exam. Even if you don't know something, you get stuck, please tell yourself that it is all okay. Everything is going to be good. Relax and move on. The more relaxed you remain during the exam, the better is going to be your performance. All the best from my side. This is Dr. Gaurav Nagpal from Ophthalmology. Hope to see you soon at Cerebellum.
So friends, this is the final booster dose just prior to your actual examination. I am your very own Dr. Vivek Jain for PSM. So friends, let us start with important things you need to know. Fishbone diagram is a cause and effect model, also known as Ishikawa diagram. In this all the risk factors are the part of the skeleton of the fish, and the mouth of the fish is the outcome or the disease. So you can see these are the different causes, and ultimately it leads to effect or the disease. So Ishikawa model, this is known as sufficient component cause model. For any disease to occur, there is one necessary cause, but there are many other component causes. If you look at this particular example, you can see that it is B which is the necessary cause. It is present in each of the pies, whereas other A, C, D, E, F, G, H, I, so on, they will be component causes. Necessary plus component is sufficient to cause the disease. This model was given by Rothman. Evidence-based medicine pyramid, which was given by David Lawrence Sackett, tells us that at the top is meta-analysis, which is the gold standard of evidence-based medicine. At the bottom of the pyramid, below expert opinions, are the animal research and in vitro research. Correct sequence for randomized controlled trial, when you look, it includes first inclusion and exclusion, who should be there in the trial. You randomize them so that you can eliminate selection bias. This randomization is done while dividing the sample population into experimental and reference group. Then you do blinding of the treatment. One group gets treatment, one gets placebo, or new treatment versus old treatment. And finally, there is analysis. Intention to treat trial is when results are not affected by attrition while final calculation, and they are not excluded, they are included in the final results of RCT. Among all the treatment guideline protocols, you must know that actually the answer lies in the last alphabets: observational studies in epidemiology, systematic reviews and meta-analysis prisma, observational studies in epidemiology, diagnosis of accuracy studies, then recommendations for intervention trials, case reports. So consort you should definitely know. Prisma you should definitely know for your exam purposes. Vaccines and cold chain. Then vaccine vial monitor, which is a cumulative heat exposure marker, is actually a marker of cold chain maintenance directly and potency indirectly. Inner square, when it is lighter than the outer circle, use the vaccine. If it is same color or darker, discard. VVM is of 4 types: 2, 7, 14 and 30. When we look at VVM2, this is for most heat sensitive vaccines like BCG, OPV, yellow fever, these are. And VVM30 is for most heat stable vaccines like tetanus toxoid, hepatitis B and pentavalent vaccines. When we look at multi-dimensional poverty index, which lies between 0 to 1 complementary to HDI, it is actually deprivation of 10 sub-indicators of 3 indicators: health, education, standard of living. Health includes nutrition and child health. Education, years of schooling and school attendance. And living standards include 6. These are fuel, electricity, assets, toilet, housing and water. Housing actually is represented by a floor. So 3 indicators and 10 sub indicators. But Niti Aayog has made it 12 sub indicators, by adding maternal health and bank account. Deprivation in more than 1/3 of these sub-indicators call it as poverty. Natural history of disease is progression of disease without any intervention. So if you look, the point C is the point where clinical symptoms and signs will appear, and it will mark the onset of clinical stage. Now, when we look at types of screening, you must know annual health checkup is applied on large number of population where we use more than one test to detect more than one diseases. So we are talking of multiphasic screening. But if you are looking at HIV in commercial sex worker, high risk or selective. Also, if you try to find out disease in family members and relatives of genetic disorders, that is also high risk selective. But opportunistic screening is something like rheumatic fever, rheumatoid heart disease in school children 5 to 15 years. Now, Kaplan-Meier survival analysis curve. We can compare in this particular example that definitely treatment B is leading to higher survival 50% even after 48 months of diagnosis, whereas without treatment only 10 to 15% survival is possible. Now, Kaplan-Meier curve, 95% confidence interval. We recommend which bands to be used. Those are Hall-Wellner bands. We can also use Nayer's equal precision bands, and to compare different survival curves, we can use log rank test, which is based on p-value. Demographic cycle, India is in stage 3, where birth rate, green line is declining, death rate, red line is declining, and total population is in late expanding stage, yellow line. Then after that, stage 4, where both birth rate become low like death rate, population will stabilize. And finally stage 5, where total population will decline. Why it will decline? Because death rate may remain same, but birth rate can decline to any extent. And this movement of a country from first till fourth phase, high birth rate, high death rate to low birth rate, low death rate is known as demographic transition. Population pyramid, age sex pyramid, which is a double histogram having females on the right side. This is a population pyramid, age sex pyramid of developing countries like India. Why? Developing countries like India, they have upright triangle with broad base, narrow top, indicating high fertility, high young age dependency. It also has lesser height as compared to developed country because it is lesser life expectancy, and it is asymmetric also, lesser females, unfavorable sex ratio. When we look at RCS program of India, it has got two IUDs, copper T 380A, having a shelf life of 10 years. And now we have also introduced multi-load copper T 375, having a shelf life of 5 years in the program. So two of them are available now. Now, when we look at HEED-AS, this instrument is used for psychosocial interview or evaluation of young people, especially adolescents. Earlier it was known as HEED-AS, but now components include home, education, eating, that is the food habits, activities, drugs, alcohol, that is the substance use, sexual life, self-harm, suicide, safety, and social media usage. When we look at Poshan Abhiyan, that is National Nutrition Mission of India, it wants to make India malnutrition free by 2022. It has identified 4 disorders. Sula pneumonic. Stunting has to be reduced by 2 percentage points every year prevalence wise. Undernutrition again reduced by 2%. Low birth weight again by 2%. Anemia reduced by 3%. That is Anemia Mukt Bharat. Health belief model has got 3 components. Let's look at that. We have perceived threats, we have evaluation of behavior, and we have the modifying factors. Now in this health belief model, if we want to have action, the final output we desire, then central to all of them is the component of motivation. In trans theoretical model of behavior change, first step is pre-contemplation. Person is not aware that his smoking is a problem. Then comes contemplative stage, in which he is now aware about the problem of smoking and the risk it can pose to his life and health. Preparation. Now a person is ready to change. And this readiness to change is within next 30 days. He may have attempted this in last 1 year but failed also. Then comes action. Action means he actually now quit smoking. There is a behavior change, but this is less than 6 months. Once it goes above 6 months, this is the maintenance phase. And finally, when do we have termination? This is when the person has no fear of relapse of the smoking again. When we look at Langlier's saturation index, it has got 5 components: hardness, total dissolved solid, alkalinity, pH and temperature. Its normal values lie between minus 0.30 to plus 0.30. If it goes below minus 0.30, we call it as LS negative. It indicates now there could be corrosion of the pipes and the boiler systems or the other equipment which are used. But if it goes above 0.30, LSI becomes positive. It may lead to actually scaling of all the pipe supplies, systems and the equipment involved. When we look at Anopheles larva, is rest parallel to water surface because it has got no siphon tube like our nose, so it rests parallel to water surface. Directly oxygen could be absorbed from water surface and the skin. In contrast, Culex larva has a siphon tube, so it rests at an angle to water surface. Aedes larva also has a smaller siphon tube. And when we look at Mansonia, it is attached to roots of the plants to derive oxygen. Now this is the formula of standard deviation, most commonly used measure of dispersion. Why? From the given value, you are subtracting the mean value. So you are calculating deviation. To remove negative sign, you are doing squares of all the deviations. You can see square. After that, you take their sum, divide by sample size. So now you have taken mean of those squares of deviations and then you apply a root of that. Root of mean of squares of deviation, RMSD, is popularly known as standard deviation. This is a box and whisker plot where data is represented in form of a quartile. So middle line is the quartile 2, this is quartile 1, this is quartile 3, having minimum, having maximum value. When you look at the first box and whisker plot, also known as candle chart, you can see it is bilaterally symmetrical bell shaped. Normal distribution. Mean, median, mode are same. Look at second graph. Here, longer tail is going towards right side. So this is right or positive skew. Mean is greater than median is greater than mode. Look at third graph. Longer tail here is going towards left side. Left or negative skew. Mean is less than median, less than mode. Look at the fourth graph. This is symmetrical, but it also has outliers. Theories of disease causation says, if you put profit ahead of health, that is Marxist theory of disease causation. Feminist theory is due to role of females enforced in society by males. Pearsonian theory says disease occurred due to, yes, social constraints or limitation. Foucauldian theory says disease divides population or segregate them into groups, making them easier to control. Macnion theory of tuberculosis says whatever reduction has taken place in incidence and prevalence of TB is due to change in socio-environmental conditions. Screw feed technology is based on the principle of high temperature but non-burn dry thermal technology. So we mix waste with a neutralizing material, inertizing material like cement lime, put it in the rotating auger and we give heat from below. It reduces weight by 20 to 25% and volume by 80 to 85%. Please remember, it is applicable for all forms of infectious waste and sharp waste. It should never be used for radiological, cytological or pathological type of waste. When we look at disaster cycle, please remember response, rehabilitation, reconstitution. 3 R's constitute recovery phase, whereas risk reduction phase is constituted by mitigation, prevention of conversion of hazard or risk into disaster, how you are doing to minimize the damage, and preparedness before the next disaster strikes. When we look at this is a life cycle depicting Nipah virus. Why? You can see consumption of fruits contaminated with bad secretions like date palm syrup. This is a category C bioterrorism agent also. When we look at National AIDS Control Program, HIV, different types of populations, then there are 3 types: high risk population, general population, and in between how will it reach from high risk population to general population is by bridge population. So when we look at high risk population, this will include commercial sex worker, men having sex with men, that is homosexuals, injecting drug users and trafficked females. General population, this will include women, children, youth and men. So who is going to act as a bridge between them from high risk to general is clients of sex workers, partners of IUD, migrant laborers, long distance truck drivers and populations in conflict. So please remember, truck drivers are a part of bridge population group. When we look at Anemia Mukt Bharat, it has got 6 by 6 by 6 strategy, where we have 6 beneficiaries, 6 interventions, 6 institutional mechanism. We want to reduce prevalence of anemia by 3 percentage points every year from 2018 to 22. Iron folic acid supplementation in children below 5 years. This is 20 and 100 milligram and microgram respectively bi-weekly. Then we give weekly 45-400 to children 5 to 9 years. Adolescent gets 6500. Non-pregnant, non-lactating reproductive female, pregnant lactating female also get 6500. Pregnant lactating get it once a day for 180 days each. This program is linked with deworming program where albendazole is used. National Deworming Day is on 10th of February, repetition on 10th of August. When we look at ICER, what is ICER full form? This is incremental cost effectiveness ratio. As the word is telling you, it is used in the technique management of cost effectiveness analysis. How do we calculate it? Difference in cost divided by difference in effectiveness. When we look at bioterrorism agents, please remember most dangerous is smallpox, most commonly used anthrax because it is most easy to use, and most lethal toxin is botulism. Nipah and hantavirus, these are new emerging category C, and food water safety threats are in category B. Biosafety levels, if you look, category 1, biosafety level 1 includes non-pathogenic. When we look at COVID-19, it is in biosafety level 2 also, 3 also, but a better answer is biosafety level 3 because we do viral culture and isolation. And dangerous pathogens like Ebola, Marburg, Lassa, Hendra, they go into biosafety level 4. Friends, I have to remind you that this is the make or break time. All the ranks are made in this period only. So what are you waiting for? You have put in so much effort. Just stay on course for next 24 hours. Just keep on focusing till the last minute of the exam. And I'm sure you are going to get a desired result. And like me, you will achieve what you wanted to achieve from your professional career. All the best.
Hey guys, Dr. Dilip here. Welcome back. And I know you guys will be a bit anxious with regards to what's going to happen with the INI-CET exam tomorrow. But trust me, guys, you have done the hard yards and you have run so far just to reach there. So keep your confidence level high and enter your exam hall with a lot of confidence. And these are my personal favorites with regards to INI-CET exam. Knowing INI-CET for almost a decade now, I can predict certain questions and these are my personal favorites. Let us start with cardiology and the diagnosis and management of acute coronary syndrome and how to manage a STEMI, end-STEMI and unstable angina. All of them are going to be very important. Last year also they have asked an ECG with regards to the post-valve myocardial infarction and you all know that. And arrhythmias and their management is always an INI-CET favorite, especially the AVNRT, the AVRTs, the pre-excited atrial fibrillations, and what not to do in the setting of arrhythmias. All those things are quite important in INI-CET. And myocarditis has always been a favorite topic. And I can expect a question from a cardiac MRI perspective as well with regard to the late gadolinium enhancement and the criteria used in myocarditis, that is the Lake-Lewis criteria. So you might expect those things because this has been traditionally an INI-CET favorite. And CPR guidelines, no need to mention. In any exam, this is an examiner's favorite. Last time they've asked a question on post-ROSC management, and INI-CET always tend to repeat the same area over and over again, but make sure that you learn everything about the return of spontaneous circulation and its management. And one update that I want to mention in cardiology is with regards to the mavacamten. That's a cardiac myosin inhibitor. And recently, there was an update with regards to mavacamten on HCM as well. It's already been approved, but they tweaked the update a little bit. But nevertheless, the drug as a whole in HCM and it can be used, can be asked in exam. Coming to endocrine, you know that diabetes is going to be the most important topic in any exam for that matters, especially with regards to the SGLT2 inhibitors, the GLP-1 receptor agonists, and the new one, the tirzepatide, which is very important in terms of obesity, and all those things can be asked in exam. The drug choices in diabetes, please don't forget that. Coming to the thyroid disorders, Graves' orbitopathy has always been an INI-CET favorite. Never ignored that topic. And diabetic ketosis and management is kind of a darling for any examiner. And they might twist the question anyway, they can ask in any way. Just be clear about it. And last year, we got a lot of questions from the MENS syndrome, that is multiple endocrine neoplasia syndromes, and from the APS as well, that is autoimmune polyendocrine syndrome, including the cardiac complex. Please don't forget that. So the MENS, the MEONS, and the APS, never forget. Cushing's, yes, possible. I cannot say with certainty, but yes, it is possible that you might get a couple of questions from Cushing syndrome. And don't forget the pseudo Cushing's that can occur in stressful situations, alcohol, depression, so on. That also is a kind of an INI-CET favorite. And other genetic disorders like androgen insensitivity syndrome has always been a darling for any examiner. And don't forget the Kalman syndrome as well. And a couple of updates here and there. Tirzepatide, which is kind of making headlines after the semaglutide Ozempic saga. So it's a kind of a dual agonist GLP-1 GIP agonist, very efficient in treating obesity and diabetes as of now. And we have another drug called as crinecerfont. So that has been approved for congenital adrenal hyperplasia, especially in the classic forms of 21-hydroxylase deficiency, which has been effective in reducing the androstenedione levels. And it also effectively reduces the amount of corticosteroids that is required for treating this disease as well. So that could be asked in exam. Don't forget these two drugs. Coming to nephrology, AKN management, especially with regards to the acute tubular necrosis, indications for renal replacement therapy, the AIOU, and always been an INI-CET favorite. And renal tubular astosis, don't forget the type 1, type 2, and especially the type for the hyperkalemic RTA. All those things are quite important. And the electrolyte disturbance, especially hyperkalemia and hyponatremia, has always been an INI-CET favorite. And complications of CKD, especially with regards to how we are going to manage a CKD patient conservatively, especially with regards to the diet planning of non-dialytic CKD is kind of quite important. I think they might ask about the KDIGO's new recommendations of SGLT2 inhibitors on almost all patients with CKD to reduce the progression of CKD. Could be asked in this exam. And don't forget the complications of renal replacement therapy like dialysis disequilibrium syndrome, the beta-2 microglobulin resulting in amyloidosis and all those areas. And here's a kind of an update in nephrology. There is a drug called lorundrostat, which is a kind of a aldosterone synthase inhibitor, a novel drug that has been evaluated for the treatment of treatment-resistant uncontrolled hypertension. It's been quite effective. The trial has been released in the last week. And we have amiloride-based trial. So amiloride has been compared with spironolactone with regards to resistant hypertension again, and they proved like amiloride is almost equal to spironolactone in this regards. So these two things can be asked. Coming to neurology, stroke is such an important topic in any exam. You go to USMLE, MRCP, Australian exams, like any abroad exams or Indian exams, you go, stroke is such an important topic, especially the localization of stroke, and more importantly, the management of ischemic stroke and TA becomes extremely important. The BP targets for ischemic stroke and hemorrhagic stroke also can be asked. Be clear about that. And other neurological emergencies like status epilepticus and alcohol-related problems like Wernicke-Korsakoff syndrome, and we have alcohol withdrawal state as well. So all those things can be asked in exam. And peripheral neuropathy has always been an INI-CET favorite, and I believe that GBS is such a hot topic right now after the Pune outbreak. So you can expect one question from Guillain-Barré syndrome for sure. And INI-CET has always targeted subacute combined degeneration of spinal cord in variety of different clinical scenarios, which will depict either B12 deficiency or probably a copper deficiency. And don't forget that. Here's an update with regards to neurology. They have tried endovascular therapy for medium vessel occlusion. Previously, it's been only for large vessel occlusion. They have tried for medium vessel occlusions and they found no benefit. So the guideline still stands the same. So you have to try EVT, endovascular therapy, only for large vessel occlusions, not for medium vessel occlusions for sure. Coming to rheumatological standpoint, so spondyloarthropathies has always been an INI-CET favorite, especially ankylosing spondylitis. They will ask a lot of questions about Reiter syndrome, psoriatic arthritis, and even enteropathic arthritis. But my hot favorites would be ankylosing spondylitis and probably reactive arthritis. These two are going to be my favorites. And autoimmune vasculitis, quite important, especially the Henoch-Schönlein purpura IgA vasculitis, Kawasaki disease, and Behçet. I believe that this year also the question is going to be repeated. And systemic sclerosis, especially with regards to those antibodies and what are the manifestations, quite important, and maybe treatment of complications of systemic sclerosis and all those. And ANA and associated antibodies are quite important. The patterns and the different antibodies which correlate with various diseases and various problems and all those things can be asked. And with regards to rheumatoid arthritis and SLE, the management part is, I feel, is going to be the most important, especially with regards to how we are going to manage an RA with DMARDs and what are the side effects of those DMARDs. Keep a watch on that. And coming to the update, there has been a trial with regards to obinutuzumab, which is an anti-CD20 monoclonal antibody like rituximab. It's been combined with the standard therapy like corticosteroids and mycophenolate mofetil in patients with active lupus nephritis, and they found a lot of benefit on the addition of obinutuzumab. So that could be a very important point as far as INI-CET is concerned. Coming to the ID perspective, the tropical infections has always been a hot topic in INI-CET. Any tropical infection can be asked, right from your malaria to dengue, to typhoid fever, to scrub typhus, to melioidosis, leptospirosis, any of this can be asked. So keep a watch on those tropical diseases. And HIV, TB, very important. So especially I believe that IRIS part, the immune reconstitution inflammatory syndrome, the latent TB infection and its treatment, the core risk groups, last time they asked that in HIV, and the post-exposure prophylaxis, all those things are going to be quite important. Know about the side effects of those drugs used in HIV and TB as well, especially bedaquiline and its QT prolonging effect and so on. Coming to HAP and VAP. So again, this has been a INI-CET favorite. Previously, they've been asking a lot of questions on community acquired pneumonia and curve 65. Now, I think it's time they will shift their focus towards HAP and VAP. Coming to infective endocarditis, the antibiotic treatment, the indication for surgery, and the prophylaxis of IE is going to be quite important in exam. And don't forget the viral and autoimmune encephalitis. Previously, they've been asking a lot of questions on bacterial meningitis and meningoencephalitis. Now, I think they might shift their focus towards viral encephalitis and probably a variety of antibodies that lead to autoimmune encephalitis like anti-WHO, anti-U, anti-RE, anti-TR, and anti-GAD65 and so on. So, but my personal favorite will be anti-NMDA receptor antibody-related encephalitis and probably anti-WHO encephalitis related to small cell lung cancer. And when it comes to INI-CET, they tend to target sometimes on organisms that you rarely remember, like Burkholderia cepaceae complex. They have asked a couple of times, and Enterococcus treatment, they asked a couple of times. We know the algorithms for treating all these infections, so keep a watch on that as well. And one update, not a very important one, so BCG revaccination has been tried in adolescents to make sure that it's effective in preventing TB in the future or not. The trial came out negative. It is ineffective. That's what the trial is. So that might be a talking point right now in INI-CET. Coming to gastro and hepatology, so treatment of chronic liver disease and its complications, especially with regards to acute and chronic varicose bleed management and management of cirrhosis as a whole and ascites with regards to the sodium restriction and the spontaneous bacterial peritonitis, the SAG values and diuretic ratios, all those things become very important. And IBD treatment, especially keep a watch on those latest advances. With regards to ozanimod that's been approved, then we have ustekinumab, then we have the vedolizumab. So all those things can be asked in exam. And tofacitinib and upadacitinib has been approved in IBD, not baricitinib though as of now. So that can be asked. And what about esophageal disorders? The echalacia cardia has been an evergreen question, and especially with regard to the findings of high resolution manometry. Keep a watch on that. And other motility disorders like jackhammer esophagus, nutcracker esophagus, and even diffuse esophageal spasm can be asked. And hepatitis B and hepatitis C virus serology, quite important, and treatment, especially for hepatitis B, the tenofovir or entecavir, and for hepatitis C virus, we have the sofosbuvir velpatasvir combination and glecaprevir pibrentasvir combination, and these are nothing but the DAs that are extremely effective in treating any genotype as far as HCV is concerned. All those things can be tested in exam. And alcoholic hepatitis, don't forget, again a hot topic, a hot favorite of any examiner, the matrix discriminant function, the Lilly score, and all those things. And MASH, the NASH has been renamed right now as MASH, that is metabolic dysfunction associated steatohepatitis, that can be asked in exam. And one update with regards to MASH is the fact that resmetirom remains the only FDA approved drug for MASH as of now. There have been a lot of drugs in the pipeline, but this is the only FDA approved drug so far. It's a thyrotropin receptor beta agonist, TR beta agonist. Coming to hemato-oncology, management of anemia, especially the nutritional anemias like iron deficiency and B12 deficiency, always been a hot favorite for any exam, including INI-CET exam. Oncologic emergencies, especially the tumor lysis syndrome, and make sure that you don't mark for urinary alkalization in tumor lysis syndrome, because that should not be done. And hypercalcemia and its management with regards to IV fluids and IV bisphosphonates plus IV calcitonin salmon, all those things can be asked. And SPC syndrome and its approach is quite important. And management of AML-ALL with regards to the management of leukostasis and the chemotherapy regimes that's been used, the modern drugs that's been approved for AML-ALL. Again, a very important topic for INI-CET especially. And management of various plasma cell dyscrasias, especially I believe multiple myeloma and smoldering myeloma is going to be a talking point in this exam, because this has always been an INI-CET favorite and we have discussed in detail in our classes. And daratumab is an anti-CD38 monoclonal antibody, previously has been used in high-risk multiple myeloma patients, but now a trial has evaluated that and have shown to be effective in high-risk smoldering myeloma as well. So previously we have not been treating asymptomatic smoldering myelomas, but now you can treat with daratumab to reduce the risk of progression to frank multiple myeloma, that too in high-risk patients. Yes, this can be asked in exam. Coming to the last one, that is pulmonary medicine and critical care. The spirometry patterns has been always important. And remember, even if the FE1 significantly changes to value of more than 12% or more than 200 ml in COPD patient, don't change your diagnosis to bronchial asthma. That's a very important take-home message I want to mention. And pulmonary hypertension has always been a favorite, and currently you can use inhaled nitric oxide for the management of pulmonary hypertension. Previously it was only for ICU patients. Now in emergency situations you can use it as well. And OSA treatment has always been a very important topic in exam. I would say as a whole, it's a very important topic. You know, the gold standard is CPAP, but there have been a lot of new mandibular advancement devices that are coming up. So that could be the potential talking area in exam. And Sagamedics, never forget, with regards to neuromuscular blockade, has been asked quite a few number of times in the last few years. And lastly, an update, that drug called brensocatib, which is a TPP1 inhibitor that has actually reduced the rate of exacerbations, and it has reduced the rate of decline in FEV1 in patients with bronchiectasis. Technically speaking, brensocatib at a dose of 25 milligram has shown this effect, not the 10 milligram one, but that much details are not important. Just remember the drug name alone, that is brensocatib. So I think we have completed the most important things that has to be remembered for INI-CET exam, and these are the updates as well. So keep a watch on those, and wishing you all the very best, guys. Thank you very much.
Hello friends, hope you're all doing well. And let me tell you, these are some of the topics that I expect to be asked in the upcoming INI-CET exam. So these are based on PYTs. INI has a lot of PYTs. So let me tell you what I feel are likely to be asked. Of course, you're going to expect something from breast cancer, and they have asked breast cancer TNM staging. So they can ask you again on T stage, or they can ask you treatment based on the T stage. So something like what is an early breast cancer, what is LABC, what is metastatic, and they can ask you about BCT, the components, that is wide local excision, sentinel lymph node biopsy, and radiotherapy. So look out for this T stage, especially the T4, ABCD. And remember, fixity to pectoralis major does not affect the T stage. In thyroid and parathyroid, again, they do ask this. In the last INI, they asked about treatment of papillary thyroid cancer. They may ask you, give you a clinical scenario and ask you whether you will do hemithyroidectomy, total thyroidectomy, or nothing at all. And these are the indications for thyroidectomy. Easy indications: compressive symptoms, complications, osmosis, toxicity, malignancy. They are the main indications where you will opt for surgery. Benign diseases, asymptomatic patients, you can just wait and watch. Of course, complications of thyroid surgeries like recurrent laryngeal nerve injury, this was asked last exam. Where does it get injured? Berry's ligament or Beer's triangle. And last exam, they asked something on primary hyperparathyroidism. So maybe this time they'll ask you treatment. If it's an adenoma, then you will just do a minimally invasive parathyroidectomy. But if it's a multiglandular disease, you will do a total parathyroidectomy and you will reimplant some bits in your left or the non-dominant brachioradialis. So watch out for that. Trauma, of course. Last two exams, they have asked you components of primary survey. So you should know whatever can be done in an unstable patient is going to be done in primary survey. Maybe this time they'll ask you secondary survey, the components of ample. So watch out for that. And clinical scenarios, patient had a head trauma, they'll give you an image, CT image maybe, and ask you what is the diagnosis or the next step. Or chest trauma, they'll give you a scenario and you will have to differentiate whether it's a tension pneumothorax or a cardiac tamponade or a hemothorax. Those kind of questions are popular INI-CET questions. This is something students always ignore in surgery, wounds and ulcers. You will 100% get one question from ulcer or gangrene. So it will either be an image of a diabetic foot ulcer or an ischemic ulcer or a venous ulcer, something based on that. Grades of pressure sore came in INI-CET as well as in NEET PG. So you must know the 4 grades. Look at what is visible. Don't look at what is lost. So if I can see the subcutaneous fat, it is a grade 3. If I can see the muscle or the bone, it is a grade 4. Think like that. And of course, I am quite looking forward to something being asked on negative pressure wound therapy. This is something that is used for non-healing wounds, bad, dirty, infected diabetic foot wounds, or like you see in this photo, laparostomy where the abdomen could not be closed, or a burst abdomen for dirty wounds. In clean wounds, either you close them or you put a graft, or if need be, a flap. Coming to flaps in head and neck, you will again get one question. Usually, they will ask you something from salivary gland surgeries, complications of parotid. You should know the nerves injured, Fraze syndrome, or submandibular gland surgery. You should know what nerves are injured. Those 3 important nerves: lingual nerve, hypoglossal nerve, and marginal mandibular. Last time they asked TNM of oral malignancy. They had given a photo and asked you the T stage. I feel this is a likely repeat. Okay, these kind of questions do get repeated directly. Images of flaps in head and neck and breast. So this is the PMMC flap. At least you should know PMMC flap, DP flap, radial free forearm flap, those kind of flaps, and tram flap and DIAP. These 4-5 flaps images you should know. GIT, of course, 3-4 questions will come. Recently, they have been asking on complications of gastric surgeries. Last time they asked during splenectomy, what vessel will get injured connected to the stomach. That was short gastric. They can ask you nutritional complications after gastrectomy, like iron deficiency or B12 deficiency, or dumping, which was asked a few years ago. Risk factors for colorectal cancer, drugs which may reduce the risk, like aspirin, metformin, I feel is important. And of course, the colonic polyps. Imaging and intestinal obstruction, this is surgery, radiology combined. So a particular disease, they will ask you the image, like a coffee bean of sigmoid volvulus or intussusception or meconium ileus. And hernia, very popular INI-CET topic. I feel this time they will either ask you on something on the mesh, like the different places where mesh can be placed, or they'll give you an image like this. This is an IPOM mesh. Remember, you can see the intraperitoneal contents. It's an IPOM mesh. This device is a tacking device or a tacker, and the mesh used in IPOM is a dual mesh. It's a the lower side should be non-adhering. It is made of collagen. The upper side can be polypropylene. Okay, so watch out for that. HPB questions can be very straightforward or they can be very tough. So if it's very tough, don't break your head over it. Like last time they asked Hanover classification or bile duct injury. Those kind of questions you cannot handle, but normal questions, liver abscess asked last year, should come back, either liver abscess or hydrated cyst. Every time they're asking acute pancreatitis, maybe now they'll ask chronic pancreatitis surgeries. At least you should know Fraisse procedure, Puestos procedure, and one question from HPB tumors. Last time they asked CA gallbladder, maybe this time it will be pancreatic tumors. Urinary TB, one of the favorite topics for INI-CET. So they can ask you diagnosis, sterile pyuria, putty kidney, or a cystoscopic image of Gulf-Hole ureter. Imaging in urology, which is also going to be covered in radiology. So one image radiology in urology is going to be asked. It's quite commonly asked. This time I feel they will ask you something from testes, especially benign testicular disease in children, like cryptorchidism or testicular torsion or varicocele. And recent advances, last 2 exams, lot of laparoscopy related things have been asked. Maybe varies would be something easy. Staplers like this, circular stapler, easy to identify. Trocars, optical trocar, metal trocar, you know. Maybe if they want to put a googly, instead of asking you a normal open surgery instrument, they may ask you a laparoscopic instrument. Just one instrument you should know. This is a laparoscopy instrument. It looks like a hemostat in open surgery. You know, this is how hemostats are. They have serrations, they have a curved tip. This hemostat-like instrument, it's actually a dissecting forceps. It's called Maryland. Okay, Maryland forceps used in laparoscopic surgeries for dissection. So few these kind of things you can very well expect. Remember, INI-CET focuses a lot on PYTs. Some questions will be outrageous, don't worry about them, but the easy questions you must get right. Hope you found this useful, guys. Keep studying hard.
Hi everybody, I am Dr. Rena Chawla, Faculty of Obs and Gynae, and at the outset I would like to wish you the very, very best of luck for the exam. You have to go there with a calm mind. Remember, the paper should not overpower you. You should overpower the paper. That's the most important thing. Don't let the paper get to you, no matter how difficult you think it is. Now, from Obs and Gynae, this is your final go through. What are the most important topics which I will help you quickly revise? First is preeclampsia and eclampsia. This is a very important topic. A lot of things can come from here. Very important. There's a lot of emphasis these days on prediction of preeclampsia, eclampsia. We know this can be done based on a history, mean arterial pressure. It can be done based on biochemical markers. It can be based on an ultrasound Doppler of the uterine arteries. And when do we do this? The best time to do this is 11 to 14 weeks. Now, when it comes to history, there's something new called the Gestosis score, which is just a history-based prediction. This is developed in India. And a score of more than 3 would want you to start the patient on low-dose aspirin. So once you predict, preeclampsia, you're going to prevent it. How will you prevent it? By aspirin, low dose aspirin, 75 to 150 milligram per day, and this should be started before 16 weeks of pregnancy. Also remember that in the ultrasound Doppler, we're looking at the uterine artery pulsatility index. If it's more than 1, it's a risk factor for preeclampsia. Which preeclampsia? Early onset preeclampsia, that is preeclampsia before 34 weeks of pregnancy. So prediction is very important. Prevention, there's a lot of emphasis these days. And then there's a lot of questions which come directly from eclampsia. Eclampsia, remember, magnesium sulfate is the drug of choice, and toxicity, that is monitoring of magnesium toxicity, is very important. So we clinically check for toxicity based on the deep tendon reflexes, based on the respiratory rate, which should be more than 10 per minute, DTR should be present, and the urine output should be more than 30 ml per hour. If any of these are there, she is going into toxicity. You need to do serum magnesium levels and give the antidote, that is calcium gluconate. So preeclampsia, eclampsia is a must topic. Then next important topic is antepartum hemorrhage and placenta accrete syndromes. So in antepartum hemorrhage, we should know the basic differences between placenta previa and abruption. Clinically, what do we see? Placenta previa is a low-lying placenta. Remember, it's going to present with painless bleeding. Abruption is going to present with painful bleeding. In placenta previa, the amount of bleeding the amount of shock will be in proportion to the amount of bleeding. In abruption, the patient can be in shock, but the bleeding will be very minimal. That is because there could be concealed abruption. So when there's concealed abruption, there's going to be a tense, tender uterus, and the uterine height will be more than the POG. In placenta previa on examination, the uterus is usually relaxed, but malpresentations will be common, and the fetal heart rate is usually good in placenta previa. In abruption, there's usually fetal distress or even fetal death. Right. Now, also important, remember that placenta previa, because it comes as warning hemorrhages, recurrent episodes of bleeding, there is a role of expectant management. You can wait. It's called the McAfee-Johnson management till 37 weeks. We wait. And once she reaches 37 weeks, or she has excessive bleeding, or there is fetal maternal distress, any of those times we do a emergency cesarean section. Otherwise, we do a cesarean at 37 weeks. Okay. Next is abruption. Abruption, remember, there is no role of conservative or expectant management. Delivery has to be done. And delivery, when I say delivery, it means the aim is to achieve a quick delivery. So that does not mean we do a cesarean for all. We do a cesarean only if there's maternal or fetal distress. If there's maternal or fetal distress, you do a cesarean section. Okay. And if there is no distress, so if the mother is fine, if the mother is okay, and the baby is okay, you can aim for a vaginal delivery. So you'll expedite labor, do an ARM, start oxytocin. And if the mother is okay and the baby or the fetus is dead, then also your aim is to have a vaginal delivery. So cesarean is only if there is distress and either the mother is in shock or there is fetal distress. That is important. Management of APH is important. Another category of APH comes under placenta accrete syndromes, PAS. Now with PAS, what happens? The placenta is densely adherent or invaded or perforated into the myometrial tissue. And this most common risk factor is a patient who has a previous LSCS with placenta previa now. Always anticipate placenta accreta. Now whenever you have placenta accreta or morbidity adherent placenta, remember that the main goal is you have to, of course, take out the baby. So when will you take out the baby? Number one, you will take the baby out between 34 to 37 weeks of pregnancy. How will you take the baby out? Next important question is you will do, of course, a cesarean section, but this will be an upper segment cesarean section or a classical cesarean. Take the baby out, then leave the placenta in situ and directly proceed to an obstetric hysterectomy with the placenta in situ. You're not going to take out the placenta, otherwise she will start bleeding excessively. Next is important topic is PPH. Now what is PPH? We all know it's excessive bleeding. Important points in PPH, remember that the medical and mechanical management usually go hand in hand. Okay, so there is something called response bundles by FIGO. There is a first response or the primary response bundle. That's the first thing you're going to do is you're going to initiate oxytocics or uterotonics. You're going to give tranexamic acid. You're going to give IV crystalloids till the time blood is not available. Okay, you're going to correct her shock by crystalloids, and you're going to start uterine massage. This is the first response bundle. If this fails, then you proceed to the response to the refractory response bundle. That is the second bundle. Okay, and in the second bundle, that has been the second step. What will you do? You will do your mechanical measures. That is intrauterine balloon tamponade using the Bakri or condom catheter. You will do external compression, that is external aortic compression, or bimanual uterine compression. And the last thing which you will do is you'll wrap the patient in the non-pneumatic anti-shock garment and shift her to a center with emergency obstetric care facilities. So basically, the response bundles, first and second, are done in a low resource settings where medical and mechanical management go hand in hand. The next important topic is cord prolapse. With cord prolapse, remember, the important thing is that when cord prolapse happen, there could be sudden severe fetal distress. So we have to immediately need to shift the patient for a cesarean section if the baby is alive. And at the same time, so you need an immediate cesarean section. The quicker, the better, preferably within 15 minutes, the baby should be out. But while this is going on, the process of shifting the patient, you have to relieve, or if you're in a center where cesarean is going to take time, relieve pressure of the cord till then. Okay, and this can be done by different maneuvers like putting the patient in a Trendelenburg position like this, or putting the patient in a left lateral or a knee chest position, or by pushing the presenting part away from the cord. But remember, you will never handle the cord. Never ever handle the cord. So these are the important things in cord prolapse. Quickly, as soon as possible, shift the patient for cesarean. Till then, relieve the pressure of the cord. Also remember that cord presentation can also be there. Cord presentation, that means the cord is at the bottom or is overlying the cervix. It is below the presenting part. And this can be diagnosed on ultrasound, or during labor, it can be felt as a bag of worms appearance. Uterine inversion, also very important. So when uterine inversion is taking place, it usually happens when controlled cord traction is done before separation of the placenta. Importantly, the patient goes into neurogenic shock because of stretch on the uterosacral ligaments, which has the nerve plexus. Also importantly, what's the immediate step you're going to do? You're going to immediately replace the uterus even if the placenta is still attached. Wherever you are in the labor room, immediately replace it. If this fails, then you shift the patient to OT and try either manual replacement or hydrostatic replacement. Okay, again, you try manual replacement under anesthesia or hydrostatic, that is also O'Sullivan's method of replacement. If this also fails, then you proceed to doing a laparotomy and then physically everting out the uterus. Down syndrome screening, very important. In the first trimester, 11 to 14 weeks, we screen for, basically we do a combined test, which is the NT, that is the ultrasound, plus the dual marker, which is beta HCG and PAP-A. Beta HCG is increased, PAP-A is decreased. So combined is both NT plus dual marker. If this is missed, the patient usually between 15 to 20 weeks, we can also do what is called a quadruple or a triple marker. What is a quadruple marker? It is beta HCG plus alpha fetoprotein plus unconjugated estriol plus inhibin A. These four form the quadruple marker, and the triple marker is these three. Beta HCG is going to increase, inhibin A is going to increase, alpha fetoprotein decreased, estriol decreased. Alpha fetoprotein, remember, is increased when there is neural tube defects. It's going to be increased. And the best way to look for neural tube defects is an ultrasound. The newest screening method is the NIPT or cell-free DNA, where what is done, where basically cells trophoblastic cells, DNA is picked up from the maternal blood, and that is analyzed for chromosomal aneuploidies. Now, this is very, very high detection rate. It is the best screening test in terms of efficacy, in terms of detection rate, but it's also very costly. So we do not routinely offer it, but yes, it is a part of screening methods. If cost is not an issue, this is the best method. 99% detection rate it has. It can be done anytime after 10 weeks or 9 weeks of pregnancy. It can be done. Remember, if any of these screening tests, NIPT is also a screening test. If any of these screening tests are positive, you have to do a diagnostic test, either CVS. CVS can be done between 10 to 13 weeks. Amniocentesis can be done after 15 weeks, and a chordocentesis, that is umbilical vein sampling, can be done after 18 weeks of pregnancy. Now, cervical cancer screening, very important. Remember, overall, the best screening method is HPV DNA. We take it using a cervical sample and we send it for HPV DNA. This is the best and the preferred. So if you're asked the best or the preferred test, answer is HPV DNA. A close second, that means another acceptable method, is a pap smear. If you're doing a HPV DNA, it's once every 5 years. If you're doing a pap smear, it's once every 3 years. And in low resource settings, as per Indian guidelines, the test of choice is VIA. So if they mention this word, low resource, choice is VIA. If they've not mentioned anything, best investigation or preferred investigation is HPV, and acceptable investigation is a pap smear. Surgeries for prolapse, very important. Now, if the patient is very old or has any comorbidities and she's not fit for major surgery, you can give her a ring pessary, or you can try a Lee-Ford colpoclysis, which is basically closing of the vagina. If she is in the post-menopause, and this is the usual age where we see these women, what can you do if she's more than 60, 50, 60, 70, that age group's fit for surgery? Here we'll do the Ward-Mayo's repair, which is a vaginal hysterectomy plus an anterior colporrhaphy plus a posterior colporrhaphy. If she is younger, that is family complete but young patient, what will you do? You will do what is called as a Manchester or a Fothergill's repair. Okay, and where we amputate the cervix, we plicate the cardinal ligaments, and then we do the anterior and posterior repair. If she's nulliparous prolapse, young woman, doesn't have children, because of congenital weakness, prolapse is there, here you will do the sling surgeries, which are now called as hysteropexies. And lastly, if you have vault prolapse, that means post-hysterectomy, the vaginal vault has come down, then the surgery of choice is a sacrocolpopexy. Another thing you can do is sacrospinous fixation of the vault. So sacrocolpopexy or sacrospinous fixation of the vault can then be done. So that is the last topic, and I wish all of you again the very best of luck. These are the most important topics that you should just go through this once before the exam. Thank you very much.
Hello everyone, welcome to Pediatrics by Dr. Anand. So let's have a very quick revision with random questions and images. A 12-month-old child came with complaints of pain abdomen, palpable mass, and X-ray showing this appearance. So X-ray showing this appearance is this one. So what is this one? This is nothing but claw sign. So not X-ray but claw sign. So pain abdomen, palpable mass, and claw sign. Very importantly, claw sign in the contrast. So what do you think? The best answer for this question is intersusception, number 1. So claw sign. Number 2, where do you see single bubble sign? Single bubble sign, it is seen in pyloric stenosis. Double bubble sign you see in duodenal atresia, and triple bubble sign you see in jejunal atresia. If I show you this baby has a gap between the great toe and the second toe. A baby having gap between the great toe and the second toe. What do you call this finding? This is known as sandal gap. This is known as sandal gap. It is seen in Down syndrome, and the most common congenital heart disease in Down syndrome is the endocardial cushion defect or AV canal defect. Which is the syndrome where IQ is not affected? The syndrome where IQ is not affected, please remember mnemonic TTC, Turner syndrome, Treacher-Collins syndrome, and Cruzen syndrome. IQ is not affected. Very importantly, in the first trimester antenatal screening for Down syndrome, the investigation is dual marker, that is beta HCG and PAPA. In the second trimester for the antenatal screening for Down syndrome, we have triple scan and quadruple scan. Triple scan has beta HCG, alpha fetoprotein, and estriol, and the quadruple scan, the fourth one component is inhibin A. And remember the mnemonic high, H and I are high in a case of Down syndrome as well as Turner syndrome. So H for beta HCG and I for inhibin A, they are high in Down syndrome as well as Turner syndrome. And as the Edwards syndrome patient has a rocker bottom feet, he is low. H for beta HCG and E for estriol levels are low in a case of Edwards syndrome. Where do you see absent clavicle? Absent clavicle, it is seen in cledocranial dysostosis, where the patient can touch her own shoulders. And most importantly, different shape of eyes. Where do you see the different colors of eyes? So most importantly, heterochroma iris, it is seen in Waardenburg syndrome. Heterochroma iris, hetero means different, chroma means color, and iris is the colored part of the eyes. Where do you see that? Basically, you see this in the Waardenburg syndrome. So this is the Waardenburg syndrome, where the patient is like a hostel warden. Hostel warden cannot see heterochroma iris, hostel warden cannot hear hearing loss, and hostel warden most importantly has a white bunch of hair, which is known as P-baldism. Next, this patient most importantly is saying that this patient is like blowing the paper. So blowing. Suddenly what will happen after suddenly blowing the paper? She'll go to in a brief state of kind of a silence, and then again she's okay. She went in the silence. So the blowing the paper cause CO2 washout, cause hyperventilation, and that hyperventilation causes a brief seizure known as absence seizure, and the drug of choice is very importantly ethosuximide followed by sodium valproate. Where do you see Kaiser-Fleischer ring? Kaiser-Fleischer ring is seen in Wilson disease. The gene mutation is ATP7B. Copper everywhere, serum copper, urinary copper, hepatic copper, everything increases, but serum ceruloplasmin levels decreases. That is why it is the best screening method is serum ceruloplasmin level. And in the treatment, you can give a chelator, that is zinc, trientine, and D-penicillamine. Remain calm and focus. Life is very beautiful, guys. Sab theek ho jayega. You need to tell yourself, failure is the key part to success. Whatever small mistakes of the MCQs which you have done, that was the key path to success. So now you will really do well. And be humble. We all have a beautiful past. Just because you fail once doesn't mean you're gonna fail at everything. Just because you fail once doesn't mean you're gonna fail at everything. You have to have the hope in you. Where do you see champagne glass pelvis? Champagne glass pelvis you see in achondroplasia. This is the achondroplasia, an example of short limb dwarfism. Claw sign and coiled spring sign you see in intussusception, where the patient has pain abdomen, palpable mass, and red colored jelly stool. 4-year-old child came with complaints of widening of wrist. Now this widening of wrist can be a fracture, but what about bilateral widening of wrist? That could be that less likely to be a fracture. So this is a case of rickets, which is because of vitamin D deficiency, which is the active form of this vitamin D, this cholecalciferol, 125 dihydroxycholecalciferol, which is known as calcitriol. That is the active form of vitamin D. Yeah, X-ray finding very important. X-ray, what do you see in the case of rickets? This is the cupping, fraying, and splaying appearance. In the treatment, you give vitamin D therapy, 60,000 international units of sachet of vitamin D every second Saturday for 5 doses. You will give that's it. And each sachet 60,000 IU. The whole treatment is 3 lakh international units. Where do you see hair on end appearance? Hair on end appearance or crew cut appearance, it is seen in thalassemia or sickle cell anemia because of extramedullary hematopoiesis. Where do you see puff of smoke appearance? Puff of smoke appearance you see in moya disease. Bitoid spots are one of the most important question every year. It comes because of the vitamin A deficiency. This happens. Bitoid spots, it is seen in X1b. Remember X1b classification of vitamin A. You see the earliest clinical sign of vitamin A deficiency is conjunctival cirrhosis, and the earliest clinical symptom is night blindness. Next, we have history of blue sclera and recurrent fracture. History of blue sclera and recurrent fracture, it is seen in osteogenesis imperfecta, which is known as brittle bone disease. The patient will have history of blue sclera, recurrent fracture, and deafness. This is also a nice one, where the child is not able to get it from the sitting position. In this, the child is not able to get it from the sitting position. This is properly known as a Gover sign, where it looks like that he's climbing on his thighs. He is climbing on his thighs and getting coming up. So Gover sign seen in muscular dystrophy, Duchenne, Becker's, and everywhere. And D for Duchenne, D for dangerous. Duchenne is more dangerous than Becker's. That you should know. Achha, where do you see rachitic rosary? At the costochondral junction, you have this beaded appearance known as rachitic rosary seen in vitamin D deficiency rickets. Do you like her necklace? It's a photosensitive rash which is because of the sun exposure. So this is because of vitamin B3 deficiency. Vitamin B3 is niacin. Niacin deficiency causes a problem known as pellagra, and the pellagra patient will have a diarrhea, dementia, dermatitis, death. It is a photosensitive rash, and if agar hum bhutta khate hain, if your staple diet is maize, you will have this problem. Okay, consumption of which of the following cereal as a staple diet is associated with pellagra? It is nothing but the maize, bhutta, maize. Okay, I am a 10-year-old. My staple diet is this maize. Which vitamin deficiency I'm suffering from? Vitamin B3, which is nothing but the niacin. Okay, this is, and one more in inborn errors of metabolism, one more disorder which mimics this photosensitive rash. It is the Hartnup disorder, Hartnup. Hartnup disorder patient will have a same kind of rash like this. So that's it. Last question. Daily protein requirement in a 2-year-old child. So 1-year-old is 10 kg and 2-year-old is 12 kg. Roughly we all know. And the protein requirement roughly it is 1 gram per kg per day. So means 1 gram per kg per day. 1 kg baby 1 gram, 12 kg baby 12 grams. So the closest best answer for this question is nothing but 13 milligram. That's it. So these were the important questions for a quick rapid revision, a quick maybe highlighter. So thank you so much everyone, and remember, knowledge is one-time investment which will give you lifetime returns. You have to just trust yourself, trust the process, and that's it. Okay, and make sure once you open the main exam paper, just close your eyes and 5 deep inspiration and deep expiration, like 1 2 3 4 5. Full inhale, then 1 and 2 and 3 hold, 1 2 3 4 5, exhale, and then open the paper. You will be able to do better. And always remember this, in any exam or any tough situation, do like this. Please take care and thank you.
First question, which is clinical based question, is mentioning that an elderly individual is coming with itchy tense blisters on normal and also arterial plaques. What is the possible diagnosis with these clues? Yes, if you have thought of bullous pemphigoid, perfect, you are absolutely correct. It is also mentioned that Nikolsky sign is negative because it is a subepidermal blistering disorder. So Nikolsky sign will be negative. Acantholysis will also be negative. DIF is going to be positive. And here you can see these are the TENS bullae clinically, and this is the DIF picture which is showing the deposition of the IgG in a linear fashion along the basement membrane zone. And knowing the differences between the pemphigus vulgaris and bullous pemphigoid is very, very important, which is given in the slide. You can just go through this. Okay. Coming to the next question, you have the patient who is young, who is having a history of anti-seizure medication being taken for neurocystic sarcosis. Now there is development of generalized peeling of the skin, very important clue, or the examiner may also give you sheet-like epidermal peeling. This is also a very important buzzword related to this question. Mucosal involvement is noted. Pseudo-Nikolsky sign is positive and direct fluorescence is negative. So with all these clues, I hope now you are with the diagnosis of toxic epidermal necrolysis, which is going to be a drug-induced rash, which involves more than 30% of the body surface area, along with the mucosal involvement. And because there is this drug history, which is very important clue for this, always see the medication, which could be even ATT, ART, anti-seizure medication. Okay, and this peeling is involving more than 30% body surface area. It is mentioned that there is generalized peeling, but if it was mentioned as less than 10% body surface area, then you should think of the diagnosis of Stevens-Johnson syndrome. Right? And Nikolsky sign is going to be positive in the conditions where there is acantholysis as the important pathogenetic feature. But here it is called as pseudo-Nikolsky sign because the keratinocytes are undergoing necrosis but not acantholysis. That's why pseudo-Nikolsky sign is a better term. And DIF is negative. The reason is because there are no antigen-antibody complexes which are forming here. It is the direct destruction, damage to the keratinocytes which is producing this sheet-like epidermal peeling. Okay, I hope this is clear. And this is the next clinical question. 5-year-old presents with recently developed patch of depigmented skin. This depigmentation is very important, and that too it is present on one side of the body. Right? Examination reveals there is white hair, that is leukotrichia. Patient is otherwise healthy and there are no other lesions over the body. So what do you think is the probable diagnosis? Yes, if you have thought of the diagnosis as segmental vitiligo, you are absolutely right. Unlike the traditional vitiligo vulgaris, which is an autoimmune disorder, segmental vitiligo has certain neurogenic factors which are responsible for the destruction of the melanocytes in few dermatomes or segmental fashion. As you can see here, this child is having this segment of the skin having the depigmented skin. So the segment which is having the single nerve root which is supplying the skin over those areas, we are going to see the depigmentation because of certain neurogenic factors producing the damage of the melanocytes. And here two more features you have to remember in segmental vitiligo. It is a stable vitiligo. Why? Because once a dermatome has been completely involved, there will not be any more progression of the vitiligo lesions. One more thing is the treatment modality. Usually the normal traditional vitiligo is going to be with phototherapy and also medical treatment modalities. But in segmental vitiligo, the treatment will be with surgical modality. Surgical modality, that is transfer of the melanocytes from the donor side to the recipient lesional skin. Okay, this is a classical point which you have to remember. That is segmental vitiligo is stable and the treatment modality is going to be surgical. Right. Next, it is 4-year-old child developing intensely pruritic dense vesicles and small bullae which are arranged in annular clusters. This is a very important clue here in a child with this classical string of pearls or cluster of jewels, crown of jewels appearance. Very, very classical, and that too over the abdominal perineal region, periorificial areas. Right, and it is being asked, what do you think is the diagnosis? What is expected on immunofluorescence finding that confirms the diagnosis? What do you think as a clinical diagnosis? Yes, if you have thought of the CBDC, that is chronic bullous dermatosis of childhood, which is a variant of the linear IgA disease in the children. So yes, your diagnosis is absolutely right. And what are you going to see on direct inflorescence? We are going to see obviously the deposition of the IgA in a linear fashion along the dermoepidermal junction or the basement membrane zone. This is a very classical finding in linear IgA disease. And what will be the treatment modality which are going to use for this children? It is going to be with dapsone. So remember, all these are very important points. Next, this is a very favorite question of the examiner. Many recent exams also it is being asked. 3-year-old child is presenting with eczematous dermatitis, which is oozy and itchy, especially over the flexural surfaces. During infancy, there is a history that the same child was having lesions over the face and the extensors. Right? There is also family history of bronchial asthma. What do you think is the most probable diagnosis? Yes, this is a atopic dermatitis, which is very classical, in which depending upon the age group, the site of involvement of the body is going to be different. Very, very interesting this is. So in the infantile phase, the involvement will be face and the extensors. And in the childhood and in the adult phase, the lesions are going to predominantly present on the flexural surfaces. And that too, they are going to be having lichenification changes. Right? And what is the criteria used to diagnose atopic dermatitis? Yes, if you have thought of Hanifin-Rajka criteria, you are absolutely correct. So what is the hallmark feature of this atopic dermatitis? It is pruritus. Itching is very, very important symptom in these patients. So next is 10-year-old child is having this small dome-shaped papules which are having the central umbilication. What do you think is the diagnosis? Very, very simple. It is the molluscum contagiosum because of the pox virus, which is the DNA virus. And here you are able to see the lesions are present over the face. And what is this whitish core which can be expressed, which you are going to see on the biopsy as the intracytoplasmic eosinophilic inclusion bodies? They are the Henderson-Patterson bodies, which are classical for molluscum contagiosum, right? Very important for you to know this point. A 68-year-old patient develops severe burning pain over the right chest and back for 2 days, followed by clusters of the vesicles and an erythematous base, single band-like distribution that does not cross the midline. So again, this is a condition where there are vesicular lesions which are present on one side of the body, that is, they are following a dermatomal, a segmental pattern of distribution, and also the lesions are very, very painful to touch. What do you think is the most likely diagnosis? Yes, if you have thought of the diagnosis as herpes zoster, you are absolutely correct. And in this picture, you are able to see there is one famous singer, Justin Bieber. He actually got herpes zoster, which is a special type which is called as Ramsay-Hunt syndrome, in which case he was having one-sided face involvement with herpes zoster. And in the Ramsay-Hunt syndrome, there is also going to be additional features like ipsilateral facial nerve palsy will be there, and also the vesicles will be present over the tympanic membrane or the external auditory canal in this case, and also there will be a lot of pain, that is otalgia is also going to be associated with this Ramsay-Hunt syndrome, right? Next, you are seeing a man from Bihar presenting with multiple symmetric shiny nodular lesions and also diffuse infiltration of the face. Madarosis is mentioned, and you are able to see that they are bilateral distributed hypopigmented macules over the trunk. No clear sensory loss is noted, but there is nerve thickening which is easily palpable. Slit skin smear of the earlobe is showing AFB, that is acid fast bacillus, which are present within the macrophages, which are called as globi. What do you think is the most likely diagnosis with all these clues? Yes, you have thought of the lepromatous leprosy. Your diagnosis is absolutely correct. And in this picture, you are able to see this lion-like face, which is called as leonine facies. And very important close differential for this condition is PKDL, post-Kalaza dermal leishmaniasis, in which case you are again going to see the hypopigmented macules over the trunk and infiltrated nodules over the face. But what are the important differentiating features? Yes, in the PKDL, we are going to have this prolonged history of the fever. Prolonged fever history is going to be very important. And apart from this, you are also going to see slit skin smear showing the amastigotes in the Giemsa stain. And also LD bodies can be seen in the Giemsa stain. Whereas in lepromatous leprosy, you all know that there is going to be thickening of the nerves, which is mentioned in the question, and also AFB will be positive in these patients. Right? Next is this 28-year-old pregnant patient in the third trimester, now developing fever and intense burning in the flexural sites, and it is followed by rapidly spreading sheets of erythema, which are studied by tiny sterile pustules. This is a very important clue. They are sterile pustules which are present over the body, as you can see in this picture, and they are coalescing to form this lakes of pus. Again, very important buzzword. They had been taking oral steroids for psoriasis, so she had psoriasis for 3 months and it is stopped 7 days ago. So with all these clues, sterile pustular lesions, history of steroid intake, what do you think is the most probable diagnosis in this case? Yes, it is pustular psoriasis. And if pustular psoriasis occurs in pregnancy, then what are we going to specifically call it as? Yes, it is called as impetigo herpetiformis. Impetigo herpetiformis. Now a question for all of you, what will be the drug of choice in this patient? She is having pustular psoriasis, but she is a pregnant woman. So can we give acitretin, which is normally the drug of choice in pustular psoriasis? No, we cannot give because acitretin is a teratogenic medication. So now in this case, we are going to restart this patient on oral steroids, which is going to be the drug of choice for impetigo herpetiformis. And we should be very carefully tapering this steroids, till the time delivery we have to use it, and we should slowly taper it so that there will not be any severe form of pustular psoriasis developing in this patient, because steroid withdrawal is associated with the pustular psoriasis and also development of the erythrodermic psoriasis. So we should be very carefully tapering. And if the patient is having any contraindications for the steroids during the pregnancy, like hypertension or gestational diabetes, then we have the next option, which can be cyclosporin. Cyclosporin, right? So last question, which says 30-year-old male presents with non-pruritic scaly rash on the palms and soles, right? And there is moth-eaten alopecia, moist raised lesions in the perineal area, and the patient recalls of painless sore on the genitals several weeks prior, which has been disappeared. Given these findings, most likely diagnosis and which serological test should be performed to confirm the diagnosis. So by this time, I hope all of you have understood that this painless sore, which was there few weeks back, it was primary syphilis, and now the patient is having the secondary syphilis.
So to diagnose secondary syphilis, what investigations are we going to perform? It is going to be VD-RLR, RPR, which will be the investigation of choice for secondary syphilis. So these are all the important features which are mentioned in this question. So patient is having this lesions of the palms and soles which are hyperpigmented and erythematous, and there is one important sign associated with this. It's called as Buschke-Ollendorff sign. So take a alpin, press these lesions, patient is going to have deep dermal tenderness. It is positive for Buschke-Ollendorff sign, so we can say that yes, Buschke-Ollendorff sign is positive, and we can probably think that the patient is having secondary syphilitic lesions over the palms and soles. And here you can see this is a moth-eaten alopecia, and this is a snail track ulcer, and this is a condyloma lata, which can be seen in the secondary syphilis in the genitals, right? So all the very best, dear students. Do great in the exam, and we'll meet again during the recall session. All the very best.
Hello and welcome to INI-CET pre-exam prep anesthesia. I hope that all of you have now brushed up with our marathon sessions. I have taken some of these topics that I'm going to discuss with you in marathon session. So if you want to see them in detail, if you've missed out on anything, you can see those sessions. All right. So the first topic that we have is LMAs. They have been asking LMAs consistently in the last few INI-CET exams. So I have just put the picture of all the LMAs. We'll quickly identify them, and then I've given you a table which discusses all the descriptive features of the LMA, like what is the generation of the LMA and what are the special features of the LMA. Okay, so you have to go through this table and these pictures once before the exam. So this LMA that you see over here, it has a single tube coming out of it, and it is made up of silicon. This is a first generation LMA called LMA Classic. This one that you can see, it is exactly like LMA Classic, which is given above, but it is a disposable type. It is a single use first generation LMA, only one airway tube coming out of it. So this is called as LMA Unique. Okay. And this one is a slightly flexible form. You can see it's curved, flexible form of LMA Classic. So this one has a wire reinforcing inside to make it flexible. So this one is called as LMA Flexible. All right. So these are the three first generation LMAs. Now this is a second generation LMA, single use disposable type. It has one airway tube and one gastric tube behind. It has a fixation tab over here, as you can see, and it has a bite block over here. So this is our LMA Supreme. All right. Then this one is a reusable second generation LMA. It has an airway tube, gastric tube, and it is made up of silicon. And this one is called as LMA Pro Seal, most preferred LMA for all anesthesia procedures because it forms a very good seal with the airway. Okay. This one over here is actually a first generation LMA. You can see only one tube is coming out of it. It is belonging to the Ambu Aura series. This is called as Ambu Aura 40. This was asked in the last INI-CET. Ambu Aura 40 is the name given because it can be used up to 40 times. All right. So you can autoclave it and reuse it again and again up to 40 times. However, remember it is a first generation LMA because it has only one tube coming out of it. This green one that you can see over here is Ambu Aura series again, but Ambu Aura Gain. This has two tubes coming out of it, airway tube, gastric tube. So this is called as Ambu Aura Gain. It is a second generation LMA, fully green in color. This is how you will identify it. This one over here, you can see it does not have a pilot balloon. Okay, so this is called as a pilot balloon. So it does not have this pilot balloon. So its cuff need not be inflated by air. So this is your airway tube. This is your gastric tube. And this LMA is a second generation LMA called as iGel LMA. It takes the heat from your larynx and it expands the cuff, and that is how we ventilate the patient. This one over here is a special LMA called as LMA Fast Track. How to identify this? It has an endotracheal tube going inside it. It is used for intubating through the LMA. It is a multiple use one. That's why it's made up of silicon, and it has a steel handle to maneuver while you are intubating the patient through this LMA. Now, a specialized form of this is the LMA which helps in intubation, and it has a camera on top. So this is called as LMA C-Track. This one, it looks like a slipper. Slipper means chappal. This is called a slipper, streamlined liner of pharyngeal airway. And as you can see over here, it has a bowl over here where all the gastric contents get collected. So patient does not aspirate if you use this LMA. Now, these two are the newest LMAs that have come into the entire anesthesia curriculum now. So this one is called as the Buska mask. It basically does not require the cuff to be inflated. The cuff is inflated with positive pressure ventilation, and it has two openings. It has one airway opening here, it has one gastric opening over here. Okay, so both of these are there, but this is called as third generation LMA because it provides better seal and better protection against aspiration. The blue one that you can see over here is called as LMA protector, and this is actually having one tube for airway and two gastric access tubes over here. So this is basically helps even more in preventing aspiration, in clearing the stomach contents. And this is the third generation LMA that we use nowadays for any gastric procedures like endoscopy, where there is high risk of aspiration. All right. Or if the patient is having high risk of aspiration because of obesity, pregnancy, or inadequate fasting. So here I have written about all the LMAs in this table. Please go through this table. It is there in the marathon session as well, and this will help you identify any element. Now, if they give you a question where they ask you that so and so patient has been admitted, you have intubated him, and these are the settings of the ventilator. So, how do you navigate those settings of the ventilator? So, you need to know that for any patient who we are putting on the ventilator, we use something called as lung protective ventilatory settings. Now, these were actually started for patients who have ARDS, acute respiratory distress syndrome, but now we follow it all over in anesthesia and critical care. So the tidal volume that we set for every patient will be 4 to 6 ml per kg of the predicted body weight. Positive end expiratory pressure or PEEP that we set is we set a starting PEEP of 5 centimeter of water, and then from there we can increase the PEEP depending on how much the oxygenation need is of the patient. Okay, so if the patient's oxygenation need is more, you can increase the PEEP. Usually we don't go beyond a PEEP of 10 to 12 10 to 12 centimeter of water. Excessive PEEP can also cause excessive inflation of the lungs that will press on your veins which are present in the chest, like your SVC, IVC, which are draining into the right side of the heart. So if your veins get compressed, the venous return will reduce. If the venous return to the heart reduces, there is hypotension. So excessive PEEP can cause hypotension. So you have to titrate the PEEP in such a way that you are providing adequate oxygenation without causing hypotension in the patient. Now, plateau pressure means the pressure that is there in the lungs when they are inflated. So the plateau pressure in the lungs maximum should be 30 centimeter of water. It should not go beyond that. Respiratory rate of the patient is usually 12 to 18 breaths per minute. And the FiO2 that we set. So when we intubate the patient, we give 100% FiO2, pure oxygen. And then as the patient settles on the ventilator, we reduce the FiO2. Usually we come down to about 30 to 40% FiO2. The normal FiO2 that we get at room air is 21%. So we come down to 30 to 40% FiO2. And how do we know that this is enough for the patient? We do the ABG of the patient, we check the PaO2 of the patient, and we see that the PaO2 is in the normal range, that is 55 to 80. That means the patient is getting oxygenated properly, and the saturation of the patient should be around 95%. That means he is getting good oxygenation with the FiO2 that we have set. Okay. So these are the initial ventilatory settings of a patient. All right. Now, next is oxygen delivery devices. Very important to know what is the maximum FiO2 that they give. Here I have also added a table of how much maximum oxygen per minute can you give in this patient. Okay. So nasal cannula, maximum oxygen flow rate that you can give through it is 5 liters per minute. Please just correct this, 5 liters per minute. Okay. And at that flow rate, the maximum FiO2 that you can provide with nasal cannula is 40%. With a simple face mask like Hudson mask, we give maximum of 10 liters per minute of oxygen, and the maximum FiO2 reaches 60%. Non-rebreathing mask with a bag attached to it, maximum FiO2 that you can give is 80%. Maximum oxygen flow rate is 10 to 15 liters per minute. High flow nasal cannula, you can high flow means you can give high oxygen flows through it, almost up to 60 liters per minute of oxygen, and it can give a maximum FiO2 of 100% to the patient. Bag valve mask, that is nothing but mask and AMBU, will provide oxygenation of 100% when you give it at oxygen flow rates of up to 15 liters per minute. NIV again gives 100% of FiO2, maximum FiO2. Okay, and your Venturi mask, you can connect it to a flow meter, give 15 liters of oxygen per minute through it, and the maximum FiO2 that Venturi mask gives you is 66%. So this you have to remember. They have asked this again and again in INI-CET oxygen delivery devices, one of their favorite topics. Now, this is a topic that I am expecting will come in the exam this time, because we recently had a live case of malignant hyperthermia in our country. So if they want to ask you something about this malignant hyperthermia, we all know it's an autosomal dominant disease, and the faulty gene is RYR1 or ryanodin receptor 1 gene on chromosome 19. The fault is in the ryanodin receptor, which does not allow the calcium to flow out of the muscle cell into the sarcoplasmic reticulum. So as the calcium remains inside the muscle cell, there is consistent contraction of the muscle, which leads to muscle rigidity. There is excessive metabolism due to continued muscle contraction, leading to excessive release of heat, leading to hyperthermia, breakdown of the muscle, rhabdomyolysis, excessive CO2 production, hypercarbia. So all of this is seen in malignant hyperthermia. The triggering factors are inhalational agents and succinylcholine, and the treatment for malignant hyperthermia is dantrolene sodium. Okay, and how do you test for malignant hyperthermia? So you have to do a muscle biopsy of the thigh, and from that you expose that thigh muscle which you have biopsied either to halothane or caffeine, and look at how much the muscle contracts. So that is called as halothane caffeine contracture test. All right. So that's about malignant hyperthermia. Then about CPR, you need to know the high quality CPR guidelines, or what constitutes high quality CPR in adults. So that is, you have to push at a depth of at least 5 centimeter and not more than 6 centimeter, and you have to push at a rate, chest compressions at a rate of 100 to 120 per minute, allowing complete chest recoil so that the heart fills in diastole. Do not have more than 10-second interruption in chest compression. Avoid excessive ventilation. Change the compressor every 2 minutes if there is no advanced airway in place. So if the patient is not intubated, does not have an LMA, so you give chest compression to ventilation in ratio of 30:2. Okay, and assess the CPR quality. How good is the CPR using EtCO2 and diastolic blood pressure? Your EtCO2 maintained should be minimum of 10 mmHg when you're giving CPR, and diastolic blood pressure should be a minimum of 20 mmHg. Only when your values are so much, then you know that your CPR quality is good. Okay, so that is about high quality CPR in adults. In children, you have some changes over here. So the depth of chest compression is 1/3 of the AP diameter of the chest. And in children, usually if there is only one person resuscitating, then you give chest compression to ventilation in 30:2 ratio. If there are two people who are resuscitating, then you can give chest compression to ventilation in 15:2 ratio. In neonates, chest compression to ventilation is in 3:1 ratio. Okay, now once you have intubated, in adults, you give at least 10 breaths per minute. Once you have intubated in children, then we give, not at least, sorry, in adults, when you intubate, you give 10 breaths per minute. In children, once you intubate, you give 20 to 30 breaths per minute. Okay. So these are some of the guidelines. In the marathon class, I have discussed the remaining guidelines also. You should know your doses of at least the important drugs like adrenaline, amiodarone, lignocaine. Those are important. Your doses of the shock that has to be given in CPR. So please go through that in the marathon class once. Okay, now this is a picture of an infusion pump in which we have attached a propofol syringe. So this is nothing but not a normal infusion pump. If you look at this, it shows infusing CPT. So this is actually a pump which is used for total intravenous anesthesia. Okay. Now, how do you identify this? So whenever you see a syringe with propofol going as a continuous infusion, you should know that this is nothing but total intravenous anesthesia. You are inducing the patient as well as maintaining anesthesia only with IV induction agent, that is propofol. All right. So this is preferred nowadays for neurosurgery for people with malignant hyperthermia, where you can't use inhalational agents, or if you want to like perform any lung surgery and maintain the patient under anesthesia only with IV induction agents. So all of this, I don't think they'll ask you for what it is used, but they may ask you to identify this. So this is called as TIVA. Two new drugs that have come in anesthesia, they are also given through TIVA sometimes. So that they are given along with propofol. Okay, propofol will give anesthesia. These two drugs, remifentanil and remimazolam, will help in enhancing the sedation of the patient. Okay, so remifentanil, it's nothing but a fentanyl analog. It is ultra short acting. It is broken down by plasma and tissue esterases, and it has a half-life of 3 to 10 minutes. And the minute you stop the infusion of remifentanil, the patient will come out of the sedation. Same for remimazolam. It is an ultra short acting analog of midazolam, benzodiazepine. Okay, it is also broken down by tissue esterases. It is also given as a continuous infusion. The minute you start the infusion, the patient goes off to sleep. The minute you stop the infusion, the patient will wake up. Okay, so both of these new drugs help in quick in and quick out from sedation, and that's why they can come in your exam. So these are all the questions that I think are important for you all the topics that are important from INI-CET point of view. I hope that this will be useful to all of you. Thank you so much, guys.
Hello guys, so this is radiology last class before INI-CET. The aim of this class is not going to give you some extra information. You guys already know what is required for the exam. This is just a confidence booster, sort of a sense of completion that, okay, I've just gone through the important images before the INI-CET, right? So without wasting your time, let me go through the important images for your upcoming INI-CET. So the first one is an MRCP image, which is showing you the biliary tree. Now what we can see here, I can see that there are these multiple strictures, right? Can you see these strictures in the intrahepatic biliary tree as well as in the extrahepatic bile duct as well? So CHD, CBD also have these strictures, and intrahepatic biliary radicals also have these strictures. What is this? This is beaded appearance of biliary tree. And we know that this is seen in primary sclerosing cholangitis, right? This is PSC or primary sclerosing cholangitis. What extra information do we need to remember as far as PSC is concerned? So P ANCA is positive here, P for PS primary sclerosing, P ANCA positivity, and associated with IBD. Now in IBD, ulcerative colitis more than Crohn's disease association, right? So this is a sort of a capsule for PSC beaded appearance. Next image is also an MRCP image. This was asked in November INI-CET, and what we can see here, that again this is an biliary tree which has been annotated. So this is the CHD, the CBD, the cystic duct, and the gallbladder. And here we see the main pancreatic duct, which is opening above the level of CBD into the minor papilla. So here the opening is into the minor papilla, and the CBD is opening down below into the major papilla. So what is this? This is our pancreatic divisum. Pancreatic divisum, which increases the risk of chronic pancreatitis, right? Now what is this next image? This is an axial T2 weighted MRI, and I can see that there is this abnormal hyperintensity involving the tegmentum, right? And what is this appearance known as? This is giant panda or face of giant panda sign, and we know that this is seen in Wilson's disease. Wilson's disease, right? So some MRI, typical MRI appearances have recently been asked. So eye of tiger sign has been asked, PCAN, tension pneumocephalus has been asked, Mount Fuji sign we see here. I'm suspecting they'll ask this time face of giant panda that we see in Wilson's disease. So remember, if you see the prominent red nucleus, these black structures are the red nucleus, and around that you see hyperintensity, tegmental hyperintensity. Sometimes in the level of basal ganglia, you see hyperintensity involving the putamen, right? Again, it points towards Wilson's disease. What else do we see here? KF rings in the eyes, and important cause of cirrhosis in young patients, children cirrhosis, Wilson's disease, KF rings, and face of giant panda in the brain. Okay, next image. This is again an MRI, but this is an axial T1 weighted post-contrast MRI. And what am I seeing here? I am seeing a cystic structure which is showing me peripheral enhancement, right? So this is craniopharyngioma. What else will be given to you in the question? So child cystic suprasellar location, very very important, suprasellar location tumor child, if you are given, mark craniopharyngioma unless proven otherwise in the question, right? And sometimes if it is a CT, you will see calcifications in the periphery. So clinically, again, bitemporal hemanopia can be given to you in the question. Craniopharyngioma is an important brain tumor as far as INI-CET is concerned. Now, what is this next image? This is a CT scan image, and I can see there is this hypodensity, right? This is a hypodensity involving the left cerebral convexity, and it is crossing the suture. It is along the entire left convexity. So this is whole is the convexity. So if I talk about type of bleed, this is EDH or STH. This is STH. It is crossing the sutures, but it is not hyperdense. It's not bright. It is dark. So it is a chronic STH. Chronic STH. Right? Just extra information I'm giving you. For chronic STH, we do an arterial embolization. For that, we do a middle meningeal artery embolization. Since this is done in AIIMS PGI, so again this is an important important extra information that I'm giving you. Chronic SDH we do MMA embolization, not for acute SDH. Okay, some other spotters. What is this? You can see dense calcifications involving the cortex of the kidney, right? What is this? This is putty kidney. This has also been asked in AIIMS, and history will be given to you of sterile pyuria, right? So putty kidney. Now next, what is this investigation? This is CT pulmonary angiogram, which is the investigation of choice for pulmonary embolism. And I am seeing that there is this saddle thrombus, this filling defect, this black colored structure inside the main pulmonary artery. This is the saddle thrombus. CTPA, pulmonary embolism, is an important spotter for AIIMS. Now, what is this investigation? Tell me, guys. So, I can see the pelvic calyceal system, the ureter, and the bladder. So, this is an IVP. First of all, this is an IVP. And I can see that there is this filling defect in the bladder. Right? This is what is a ureterocele. Ureterocele. So, cystic dilatation of the terminal end of the ureter. This cystic dilatation does not fill up, and the surrounding bladder, when it fills up, this cystic dilatation appears as a filling defect in the bladder. Now remember, don't mark it as a calculus. Bladder calculus is hyperdense, right? So it will not appear as a filling defect. It will be bright. It will not be dark. So bladder calculus is hyperdense. It does not appear as a filling defect. This is a ureterocele. Important spotter because ureterocele has been asked previously. Some other image was given, but remember, cystic dilatation of the terminal end of the ureter. You can also be given an ultrasound image, and again in the ultrasound image you will see that at the VUJ there is a cystic structure. Now what is this structure? So this is a cyst in the liver, but you know, if you're given a liver cyst, always and always first rule out whether it is hydrated or not, because normal simple liver cyst you will not be given in the exam, right? So we see a cystic lesion in the liver, but can you see that there are these peripheral calcifications also? So calcifications, and if you look at it, there are some fine septa and some abnormal hyperdense areas. So this mixed density lesion, this mixed density cystic liver lesion, always think of hydrated first, other options later. Hydrated disease, right? And the last image, I'm going to show you a DSA. So this is a DSA. You will be asked which artery is this. So you know, you can see multiple branches of this artery. This is the actually this is the ECA angiogram, external carotid artery angiogram, and you can see various branches. So let's see the various branches. So what is this posterior most branch? This is the posterior auricular artery. Then this branch anteriorly, which is dividing into two, this is the superficial temporal artery. Superficial temporal artery. Then this main branch, which is a thicker branch, this is the internal maxillary artery. Okay. Now, what are these two branches? So these are facial artery and lingual arteries. right? So this is the ECA angiogram, which can be asked to you in the exam, right? All of us know the ICA branches, but ECA branches, a lot of people don't read as well. So ECA angiogram, hydrated cyst, ureterocele, pulmonary embolism, putty kidney, PSC, pancreatic divisum, Wilson's disease, craniopharyngioma, and chronic STH. So that is all from my side. All the very best for your INI-CET. I'll see you in the recall.
Hi friend, this is Dr. Apur Mehra and this is an all the best session for your INI exam. There are a few pointers which I want you to remember. Remember in orthopedics, the scientist remember is H.O. Thomas, who gave Thomas test for hip flexion deformities and who gave Thomas splint for TB knee initially, but now used to immobilize the lower limbs. MRI is the investigation of choice. And usually, if you don't know anything, mark MRI, you'll be good and safe. Remember one thing, tissue diagnosis is the best, especially when it comes to infections and tumors. Staph aureus is the king. Metaphysis is the most common area affected and it comes to the blood. When it comes to tuberculosis of the spine, it always involves two vertebrae, and CB-NAT is the investigation of choice for the biopsy that you take according to World Health Organization, WHO. When you want to talk about TB knee, it leads to triple deformity, and TB hip, stage 1 is synovitis with lengthening, stage 2 and 3 there is shortening with Fadir. Flexion, adduction, internal rotation of the hip. Think of posterior dislocation or think of arthritis. Whereas flexion, abduction, external rotation of the hip, think about synovitis or septic arthritis. And remember, septic arthritis versus synovitis of the hip is differentiated by something called as the Kocher's criteria. Remember, when you talk about nerve injury, the most common nerve to damage in the human body is radial nerve, which leads to wrist drop. And there is sensory loss on this area. But when its branch, posterior interosseous nerve, is paralyzed around the head of radius, it causes finger drop. Whereas the tip of index finger is supplied by the median nerve, tip of little finger is supplied by the ulnar nerve. And remember, right, the important tests are for ulnar nerve or median nerve. There is no test for radial nerve. It is the most common nerve damage, has the best prognosis. Remember, and there is no test because the topper है उसके कभी भी आप marks नहीं पूछते, वो topper है, so उसको test नहीं करते. When you look at the median nerve, the important tests for the median nerve are the pointing index. If you ask the person to make a fist, these two fingers they stand out, or the Osner clasp test, these two fingers they stand out, or the benediction attitude or the Pope's attitude. If you place a thumb over the palm and ask the patient to touch it, this is called as a pen test, right? Again for the median nerve. And the median nerve palsy, the thumb is in the same plane as palm, right? This is called as ape thumb deformity, because the main aim of median nerve or the work of median nerve is doing opposition. When you look at the ulnar nerve, you know ulnar nerve will do adduction, abduction, and this is tested by the card test, the Igawa test, abducted little finger by the Wartenberg test, or when you adduct the thumb by the book test, or when it's paralyzed by the Froment sign, remembered by the mnemonic FU. The most common compression neuropathy is carpal tunnel syndrome, where median nerve is compressed. Remember, shoulder is the most common joint to dislocate in human body, and it goes anterior and the head is down and the arm is out. Whether it's hip or shoulder, the head is down and the thigh or arm is out. And the most common misdislocation in human body is posterior dislocation of shoulder, which is commoner in epileptics or electric shock. And here the arm is up and by the side of the body, where the head is up and the arm is by the side of the body, called as up and in. When you talk about going to the further, in cases of spine injuries, remember the burst fracture is compression of the anterior and the posterior part of the vertebral body, right? The wedge fracture is compression only of the anterior part of the vertebral body, and chance fracture, the vertebra splits into two parts. When I talk about rickets, every ricket, there is normal to low calcium, low phosphate, high alkaline phosphatase, high PTH. Two exceptions, high phosphate seen in renal rickets, and remember normal PTH seen in hypophosphatemic rickets, and this is what is coming in the exams nowadays. When you talk about bone tumors, there are three bone tumors which are very commonly asked. Number one is a giant cell tumor which goes till the end of a bone, the only tumor which can go till the joint. Osteosarcoma, which is seen usually in the second decade, metaphyseal with Codman's triangle or sunray appearance, or Ewing sarcoma, usually seen in second decade more than the first decade, but diaphyseal and lamellated or onion peel appearance. And also somehow in INI-CET, they love to ask you upper end of femur like a Shepherd crook, called a Shepherd crook deformity seen in fibrous dysplasia. Most common metastasis to the bone comes from the breast, and METS is the most common bone tumor. Two conditions in which you will see hypercalcemia. One is hyperparathyroidism, primary, and the second one is multiple myeloma. So coming on to metabolic bone disorder again, remember in rickets, there is widening of the bone ends, and in scurvy, vitamin C deficiency, there is whitening of the bone ends identified by the Wimberger ring sign or the Frankel's line. Hyperparathyroidism will have brown tumors in the fingers or will have salt pepper skull. When you talk about going on to the sports injuries, remember one thing, ACL, anti-cruciate ligament, prevents the translation of tibia anteriorly on the femur, and the tests for it are the Latchman's test, the anterior draw test, the Lely's test, and the pivot shift test. For the PCL, there's a dial test. The meniscus, the peripheral 1/3 are repaired and is tested by the McMurray's test. Also remember that most of the conditions in which there is inflammation, whether it's tennis elbow around the elbow, or the golfer's the medial epicondylitis, olecranon bursitis here, or the first compartment of the wrist conducting abductor pollicis longus, extensor pollicis brevis tendon called as decurvent synosynovitis, treatment is plan A, rest plus NSAIDs, if not relieve local steroid, if not, then the surgical options are given. Painful arc syndrome is the position of the shoulder where mid abduction is painful. Remember, mycetoma is a painless condition. Remember, Charcot's joints in diabetic is a painless condition. Everything else is painful in orthopedics. And remember, the frozen shoulder is again a condition in diabetics. So diabetics, you should remember Charcot's joint and frozen shoulder, which are very commonly asked. When you come to pediatric orthopedics, remember, painless instability of the hip at birth is DDH. Investigation of choice is MRI. Remember, painless condition of the hip, which is avascular necrosis of femoral epiphysis, 4 to 10 years, almost all INI-CET they ask you is Perthes disease. And second decade in hypothyroid patient, obese, overweight, painful hip external rotation, right, is seen in slipped capital femoral epiphysis. And remember, clubfoot or CTEV is a combination of cavus, erection, varus, equinus. And remember, at birth is treated by cast, 1 to 3 years by soft tissue release, 3 to 10 years by osteotomy, and beyond that, it is treated by fusion of 3 joints, talonavicular, talocalcaneum, calcaneocuboid, called as triple arthrodesis. After the correction is done, at daytime you give CTV shoes, and at the night time you give a splint where you give foot abduction orthosis, which is very, very important. All the very best for your INI-CET exam, and thank you very much.